get started with a couple of housekeeping items. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meetings are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. Let's go ahead and get started with roll call. So Tara, will you please help me with that?
Yes, Oscar, happy to do that. And first, we'll go in alphabetical order. Oscar Arana.
Present.
All right, we know Ebony Clark will not join us today. Is Jessica Gomez with us yet? I do not see her. I will connect with her. Kristen Isaacson, our vice chair, is out today. Next, we have Brenda Johnson.
Present.
Hi, Brenda. Melina Moran.
I am present and currently troubleshooting my video.
Okay, good luck with that. Thanks for being here with us. Bill Kramer.
Present.
Thanks, Bill. Sandy Sampson. All right, John Santa.
I am present.
All right, well, thank you so much for your help, Tara. Looks like we have 5 board members, so we have quorum. Michelle, will you stop sharing your screen? Thank you. Much help, very helpful. All right, so we're a week away from the election. So this is your friendly reminder to make sure to vote. The campaign season has certainly raised a lot of discussion about OHA's work, direction, and leadership. I know that for some, the election may be creating a little bit of anxiety. It's certainly doing that for me. But OHA staff, leadership, and the board should be very proud of the work it has accomplished, especially through the height of the pandemic. I want to thank everyone for their commitment, time, and service to this work, especially as we continue moving forward, centering health equity. So please don't forget to turn in your ballot on time. And here's what we'll be covering in today's meeting. We're going to continue hearing from OHB committee liaisons that didn't get to present last month. OHA staff and staff from the Oregon Department of Human Services will provide progress updates on the public health emergency unwinding and show us a new data dashboard. We'll hear a presentation of the findings and recommendations from the Oregon Nursing Workforce Study. Also, OHPB's Healthcare Workforce Committee is seeking approval on their proposed membership slate. So please note that this is an agenda item that requires a board vote. And finally, we requested last month to hear a progress update on CCO 2.0 policy areas. So that's what we have for today. But first, our first order of business this morning is to approve the draft October OHPB meeting minutes. The draft minutes are listed as an attachment 1 of our meeting packet and are posted on the board's website for public viewing. Is there a motion to approve the draft October meeting minutes?
So moved.
Thank you, Bill. Is there a second?
Second.
Thank you, John. All those in favor, please say aye.
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 All right, anybody opposed? Anybody abstain? Okay, so the meeting minutes are approved. Okay, so last month we started getting updates from OHPB committees, and today we'll hear from a few more of those committees. We're going to start with John, who is our liaison to the Medicaid Advisory Committee and the Health Insurance Technology Oversight Committee. So John, thanks for providing a double liaison coverage to our board's committees. So go ahead.
Yeah, thanks, Oscar. So this has been a very interesting several months for me getting used to these two committees. They're very different from the activities I was involved with in the past. So let me start with the Medicaid Advisory Committee. My sense is the Medicaid Advisory Committee, and I think is consistent with some of the language we use, is more of a downstream activity. This is a group required by federal law. And actually, I've been reminded a couple times there that we don't take our orders from OHPB. We're an independent body, required by the federal government to input to the state about the Medicaid program. And they are really trying to do that. But doing so means that most of their activity is focused on reports from the agency itself. And to their credit, they're really trying to get folks reporting to them to provide their information a week in advance so they can see the slides, to reserve half of their presentation for discussion and questions, et cetera, from members, so that they can genuinely engage around these issues. And the issues they're dealing with are incredibly complex. I just am so impressed with how complex this is. And there are OHP members there who have been very participatory and very involved in the discussion. Currently, they are involved in some leadership transition. They're at the chair level. Lavinia Goto has taken over from Leslie Huggins, who just did a fantastic job. There's also a staff transition underway, but that's going reasonably well. I do think it's important for the agency to realize that the input from this group needs to be taken seriously. You all will recall that MAC presented a patient experience report, the work of a subcommittee that worked many months on concerns about the experience patients were having. We heard that report. I think we endorsed it, but we still haven't heard back from the agency what they think of the recommendations. And hopefully that will occur, as there needs to be an engagement between the committee and decision makers at OHA about issues like that. So that's MAC. HITALK, the Health Information Technology Oversight Committee, is different because I think it's what, to the best again of my sense, an upstream committee. It's dealing with issues predominantly that are over the horizon. So it's able to do a variety of things differently. Its major activity has been around the organization of community information exchanges, or CIE. I think House Bill 4150 required HITALK to put together a report on community information exchanges. Over the last several months, they've done so. And in their case, they're able to do so through a variety of more interesting approaches. Yes, they have data from surveys and other input, but they also have organized work groups separate from the committee itself, and recruited key folks involved in community information exchanges and community organizations to participate in that process. And so they've completed that, and that will go to the legislature, and I think will be presented here at some point. They're involved in a couple of other activities that I wanted to mention. Probably the most important is they have done an assessment of where we are in terms of the establishment of the information infrastructure. Who has electronic medical records and who doesn't. And the findings, I think, are important to us. Physical health providers in general, are doing quite well in terms of EMRs and putting them up and going, probably in the mid to 90% range. That doesn't include, though, some smaller sized physical health providers. What gets your attention is that behavioral health and oral health, there's a significant gap. If my memory serves me correctly, I think that about half of behavioral health providers have an electronic medical record. What does that mean? I mean, it's like they're driving their car on a very different set of roads than everybody else is. As I think we'll discuss this later on in this meeting, I think it's an indicator of the difficulties that we may have in catching them up, that the legislature didn't fund the purchase of that kind of infrastructure for behavioral health. While much of that was funded by the federal government for physical health, at least. So I was impressed with that activity. Their leadership, I think, is also in transition, and they will soon have a different chair. The staff does a superb job. They're out recruiting new membership, and there was a note about the work they're doing with the tribes, and the tribes are, I think, getting organized to try and get folks for our activities. So it's a very interesting and enjoyable activity to be involved in.
Thank you so much, John. I really like that metaphor. Very helpful to kind of understand the challenges there. Are there any questions for John? Melina, it's really nice to see you. So glad you were able to work out the video. Okay, if there's no questions for John, we're going to move over to the Primary Care Payment Reform Collaborative updates, and Chris Damaris is going to give that update.
Yeah, thanks. Hi, everyone. I'm Chris Damaris. I'm the Delivery System Innovation Director at OHA, and I help staff the Primary Care Payment Reform Collaborative. And just to give you some background before I give the specifics of what the collaborative is working on, they're doing some work that came out of or helping with the Healthcare Cost Growth Target Implementation Committee's vision. That committee in 2021, some of you may know, identified spreading value-based payment as a strategy to help address the cost growth target or achieve the cost growth target. And out of that came a value-based payment compact that has targets on increasing value-based payment. And that was created in 2021, which has been adopted by by payers and providers that cover about 73% of the people who live in Oregon. So as part of that value-based payment compact, there is a work group that's been established to help to achieve the compact's goals, and they developed a roadmap with some strategies to help support advancing value-based payment. And the first strategy as part of that roadmap is developing a short menu of value-based payment models that could be voluntarily adopted by payers across the state. And primary care is the first model that's being developed. So this value-based payment compact work group asked the Primary Care Payment Reform Collaborative to develop this primary care value-based payment model. And so there's a work group that is part of the comprised of members of the collaborative that's of payers and providers that have been meeting since May of this year and are developing a model and some of the components of the model that they've come up with so far. And the model is not final yet. It'll be final in early 2023. Our recommendations outlining a prospective payment model that would be based on services that are provided and allow for inclusion of a diverse team of care team members. Performance-based incentive payment is also recommended, and to reward high performance relative to external benchmarks. And at future meetings, the work group will come up with other recommendations around an aligned set of quality metrics and ensuring that equity and promoting health equity and ensuring that inequities are not exacerbated. Strategies are built into the model as well. So that's really been the core work of the Primary Care Payment Reform Collaborative the last quarter. And I'm happy to answer any questions.
Thank you, Chris. Anybody have any questions for Chris? Brenda.
I have a quick one. Chris, thanks so much for the presentation. I know this body of work is so critical to our recovery in our pandemic experiences. And I'm curious if the models you're describing are sensitive to the workforce crisis and the demands on workforce that we're in right now. If you could just give a little airtime to how those conversations move in that circle.
That's a really good question, Brenda. I would say that some of the conversations we've had have touched upon infrastructure payments. These are per member per month payments that could be built into the model. And the goal of those type of payments are to kind of give additional funding for practices that they can use and to bring on new workforce to meet, say, needs their members have for behavioral health, or maybe bring on a social worker or something. So we haven't, I don't think, specifically talked about the workforce crisis and kind of addressing it, but in general, a PMPM can help to address that. So appreciate the feedback, and we'll bring it back to the team and make sure that we're more explicit about that in the future discussions.
Great. Any other questions for Chris?
If I could just say one more thing in response to that, just in general, value-based payments and a prospective value-based payment that kind of includes a capitated payment allows for flexibility in how the practice uses dollars to bring on staff and provide care to members. So just in general, I think the model can be used to help to bring on needed workforce as well. So just wanted to point that out. So thank you.
Great. And Brenda, it's great to have you back. I know you've had a few excused absences during the summer. So it's great to have your perspective and voice back on the board. So great to see you. All right. We don't have an update on the Public Health Advisory Board today, but we will get an update from that committee in the next couple of months. So unless there's any other questions, we'll move on to their next agenda item. All right, OHA and Oregon Department of Human Services staff join us to provide monthly progress updates on the post-public health emergency eligibility renewals work being conducted by each agency. We'll first hear from Sarah Dobra and Vivian Levy from OHA, and then proceed to updates from Jillian Johnson and Randy Blackburn with ODHS. So Sarah, go ahead and take it away. And Sarah, you're muted.
Thanks, Oscar. I actually believe this may be the opposite. I think Jillian's starting for us.
Oh, okay.
Yes. I also think that that is what our plan is, Sarah. So thank you. Hello, everyone. Jillian Johnson. I am a Deputy Director with the Oregon Eligibility Partnership with the Oregon Department of Human Services. And here today with OHA partners to talk a little bit about post-public health emergency, PHE, and the planning around the renewals that will be happening. So our agenda is really giving you some general updates. We want to talk about the dashboard that is going to be stood up. And then Sarah will talk about the community and partner work group and their population sequencing recommendations. So that's sort of our plan for our time with you today. This is basically a timeline of how the redetermination process should unfold if the PHE ends in January, and we are proceeding as if that is what's going to happen. So if the 60-day notice is received from CMS in November, then the first mailings would begin in February. What that means is that cases will attempt to go through a passive renewal process for February, and then those that require requests for information would have those requests for information notices mailed early in February, with the information then due May 1st. And then that pattern would occur throughout the PHE public health emergency unwinding timeframe from this February of 2022 to December of 2023. And then the final requests for information would actually be due in March of 2024. And so we are moving forward with that anticipation. So that's a brief update on what that looks like. Now I'd like to turn to dashboard. So House Bill 4035 requires that OHA and ODHS partner on providing information around the redetermination process on a publicly accessible website. That House bill further sets out some requirements for what data should be publicly reported when it comes to the renewal process once the public health emergency unwinding starts. It's going to be on a publicly accessible website, and the current plan is to host the new dashboard on benefits.oregon.gov. So that's one of the most visited sites in the state, and it's where our operations reports have and are currently shared. A new web page has been designed for operational information, and it's going to be published shortly with sort of a placeholder for that new dashboard. And it's really designed from the user perspective and has gone through specific testing. So now a dashboard preview. A note that this is absolutely a draft, and so we're not considering the data accurate. At this time, what we have is a prototype, and it depicts the data. We're currently working on designing a visualization to really make that information more readily accessible to the public. And the next slides are going to show you only the concepts for how we're approaching the dashboard. They don't actually represent any final design, and the data is a placeholder, but we wanted to be able to show you what we're moving towards. So we absolutely intend to depict more information than what's captured here, but the first section really should show an overview of the state and each county. And then it'll have sort of the option to hover over the county that's in question and see more detail about the number of recipients, the cases, and then also the ability to see that data disaggregated by Real D, which is race, ethnicity, language, and disability, as well as gender, age, and houselessness status. And that is to really assist in identifying inequities and communities that may benefit from focused interventions. We are also working with our partners in equity and inclusion to ensure that we depict this data in an appropriate manner. And that means that there'll be protections in place for small numbers to avoid identifying members and recipients in the communities. Furthermore, the dashboard team is working with an accessibility specialist to make sure that we are building accessibility into the design of this dashboard. We're also going to be reporting on our progress as those medical renewals begin, and it will include how many are at each stage of the renewal process, what actions still need to be completed. We also, as in the last slide that I talked about, we plan to make sure that data is available by Real D, houselessness demographics, age and gender demographics, really to assist in identifying disproportionate impacts from that statewide perspective. And then finally, we're going to also be reporting on performance measures, such as customer service center wait time and volume, how many applications are processed the same day, next day, who is impacted by disenrollment or reductions in benefits. And then other performance measures are going to include percentages of automation on medical renewals and other automation statistics, as well as there's a one customer service center customer satisfaction survey, and we want to include that data as well. And so that's what I have on the dashboard, and I will happily hand it over to my OHA partner here, Sarah.
Thanks, Jillian. I'm Sarah Dobra. I use she, her, aya pronouns, and I do work at the Oregon Health Authority. My day job is managing our OHA OMSPUDS program. So you heard me in that context, and also another team called the Innovator Agent team working with CCOs. But as we think about really Oregon Health Authority values, I think this board has, told the Oregon Health Authority to also share we embrace as we think about health equity. Part of that is doing co-creation with community and ensuring as we make what we seek to be thoughtful decisions, we truly do that in with our community's partnership. House Bill 4035 required the Oregon Health Authority to do that, specifically around much of this Medicaid redeterminations work. And they set up a community partner work group that we've brought to you before, made up of various community members and representatives from OHP members to healthcare providers to community-based organizations, to representatives of organized labor, and also with tribal representation that is appointed, MAC representation are also appointed, and also from the Health Insurance Advisory Committee as appointed members. Some of the charges from House Bill 4035 for this group were both for the this group to make proactive recommendations, such as around communications for specific populations that we as Oregon Health Authority and Oregon Department of Human Services thinking about redeterminations should act on whenever possible, and they're doing that. We also have responsibilities to proactively come to the work group with specific areas of decisions for consultation and to take their advice whenever possible. One area that we're walking through with you today that the legislation called out is population sequencing, or the order in which we will, over that 10-month period, begin redeterminations for individuals in Oregon. So as we think about almost 1.4 million Medicaid members, we asked this work group to take technical and operational work that had already very much been thoughtfully looked at in our teams and to walk through that. Can you hear me? I think I may have just been kicked off.
We can hear you, Sarah.
Okay, I was just kicked off my screen, so fantastic. I'm glad I can still see, and I'm back on, thank you. So that's population sequencing is the order which we'll go through this. And we dove in with the work group into highly technical work that this work group really thought through, struggled with, and thought through. And one of the lessons I think just sharing with all of you as we think about this work is outreach and engagement. Individuals who can help to facilitate this work must be closely partnered with operational staff and agencies to do this work. And Vivian Levy, I think is on here, and that was just an essential partnership. So we can go to the next slide. And what this was, there were some very broad principles that the agency had really thought through, and we ensured that this really also made sense from the community and partner work group. And some of that is individuals who are most likely to keep their coverage, specifically their Oregon Health Plan or Medicaid coverage. We want to front load those cases and do those at the beginning of the redetermination period, knowing that those individuals will continue on the Oregon Health Plan and go through a fairly automated redetermination process. So thinking about protecting that. On the flip side of that, we want to backload cases and do at the end of the redetermination period, individuals who are more at risk of losing Oregon Health Plan coverage or might be moving to other services and insurances. And then thinking about some of our populations who need more intensive services to do and supports, and how do we ensure that's done throughout the redetermination. So thinking about our unhoused individuals, limited English, individuals who prefer English, a language other than English as their first language, thinking about those populations and ensuring we have staff support and time and community partner support throughout the redetermination period. So the broad principle the work group and really our agencies thought through was ensuring we keep coverage and protect individuals. With those principles, the work group, we can go to the next slide, actually dove into 8 broad categories of individuals and then 8 subcategories of individuals who, if they fell into that subcategory, tribal members would be an example, unhoused individuals would be example of subcategories. What do we do to ensure that we protect coverage? And the work group started with recommendations that our agencies had already put forward based off these broad principles, but they dug through and did detailed work thinking about the impact of that. One specific example is we think about unhoused individuals and their plan to spread throughout. Individuals on the work group who are community partners and work with our unhoused said in the month of January, we are overwhelmed with applying to federal HUD applications for housing. We will not be able to effectively support unhoused individuals in Medicaid redeterminations during the month of January. And we were able to take that back to our internal operations staff and say, great, we will not begin redeterminations work with the unhoused in the month of January to protect that for time period for our community partners who are essential in this process. This is really a visual sort of what Jillian also showed of timeline when redeterminations begin, but thinking about, and these are the work group recommendations, which do very much by and large align with what the agency recommendations were, with these very slight modifications, such as skip the month of January for unhoused. The group chose not to make a recommendation around a specific population called COVID exemptions, as they put broad values that they asked our agencies to ensure are maintained, and then gave the agencies that freedom to think through what makes sense there. And then for Native American, our tribal members, they asked that to go through the tribal consultation process rather than making a recommendation there. So that's the really broad. We do have on the following slides more the nitty gritty of what that looks like, the number of individuals impacted. And what this just helps to understand is some of these data will also be going to these dashboards, and who, how many individuals and families and cases really is what we call it, will be impacted. So this is the work that work group really dove into in a very robust way. Along the way, they also said, and we asked, do you want to, in addition to sequencing, consider other communications approaches that might be specific to picking one that's on the screen, pregnancy and newborn, but unhoused and limited any of these populations? Do you want to think about operational strategies or any policy recommendations that you might also want to make? And that's the work group, the work that this work group is now diving into is additional communications approaches, additional policy or operational changes and recommendations they want to make to our agencies. And then our agencies have the responsibility to thoughtfully consider and act on those whenever possible. So there's a few more slides on the redeterminations actual groups, which again becomes highly technical, but it's helpful to see. So I'll pause there. I want to see if Vivian has anything to add, or I'm happy to answer questions as well.
You did a great job, Sarah. I don't think I have anything to add, but yes, also happy to help answer any questions.
Brenda, looks like you have a question.
I do. What great work, Jillian, Sarah, Vivian. Thank you so much for the presentation. And I feel a little bit more confident based on the breakdown and on the analytics side of what you've shared with us today. I know it's an incredible body of work. My questions are, I've got 2, I think, for you. The first is where we stand within the agencies themselves in terms of the workforce required to accomplish this massive of a task. It sort of leads me to the question about community partnerships, but I'm curious where we stand in call wait times and how we're envisioning responding to the need.
Oh, okay. So thank you, Brenda.
Sorry.
Asking the very hard question that I don't have a super positive answer for. Right now, our call wait times are averaging 20 to 40 minutes, but our maximum times are up to 3 hours. I think it's important to include the maximum times because that is an impacted person, right? We have brought in some contractors to help with non-eligibility work, those calls that come in that are address updates and general things that aren't actually determining eligibility. To support that, we are looking at ways to maximize automation. For example, received approval and created updates to the system that allow, you know, if some information was already verified for a person's SNAP benefits, for example, then we wouldn't have to request that from the member recipient the next time, right? Because we've already verified that. So we've inputted some of that. We're also hiring what we refer to as non-budgeted positions because we know that there is this workload. And, but with all of that said, and I'll let Vivian chime in if there's more things we've been doing that, you know, she's got, but we do expect backlog and we do expect pretty big wait times because, and we've learned a lot from the previous backlogs, and we have structure in place and we have plans in place for what to do and when to sort of pivot our approach and all hands on deck, and we have sort of identified thresholds and all of that. So we have that structure, but the reality is you can only do what you can do with the people you have. Mm-hmm. And so we anticipate at some point it'll be, do we focus on new applications or we do focus on redeterminations? We would focus on the people who are about to lose benefits, right? Like, so there's going to be some balance there that we're going to have to sort of figure out as we go.
Thank
you. Do you want to add?
Yeah, just to add to what Jillian said, just to give kind of a few other examples of things we've tried to do from a policy perspective, as well as coordination with our community partners. Jillian alluded to some changes around income verification. We have taken the opportunity during the pandemic to really beef up our income verification sources, our electronic sources. And that is all really with the intention of needing less from the member or the applicant and being able to do more automatically and internally with the information and the data that we have to reduce the number of opportunities to lose people or have them not be able to respond for whatever reason. We also have a very high rate of what we call passive or automated renewal in Oregon. And I think that that will work to our advantage to help reduce a lot of the upfront processing that needs to happen so that we can really focus on verifications and member support. And then the final thing that I would say is exactly to your point, Brenda, community partners, our community partner network has always been and will continue to be invaluable to being able to reach people, to serve them, to provide them with that additional assistance that they need to stay enrolled or to move into the next type of coverage. So, you know, we've kind of said from the beginning, and I believe this even more strongly than I did in the beginning, that our success in this redetermination process will be tied directly to the relationships that we have, to how much we lift up our community partners in their ability to support people and to provide that extra help. Certainly community partners can't fill the gap that we have on our eligibility staff side, but they can make a huge difference for people who do need that extra help. So we're doing everything that we can to leverage all the resources that we have.
And this is Sarah, and I do want to just add like a little bit of, especially around House Bill 4035 and what they enabled the work group to make recommendations on. We hear every single work group session as a theme, particularly for some of our highest priority populations who we know face additional health inequities, and our health equity definition tells us we should focus on. We hear from members working with those populations specific, that relationships and trust, the ability to, we heard from our tribal representative, the ability to walk directly into a community partner with the stack of OHP letters and understand what that is. We heard that from the Oregon Law Center, that members go, they don't understand this in English, and actually take a stack of letters to an attorney because they don't know. But it's those relationships and trust. We've heard that focus on specifically ensuring access for, from our work groups, some of the specific populations are our tribal members, our Asian Pacific Islander communities, who we know have disproportionately have fewer access to healthcare. Some of our elderly and disabled populations are unhoused, and then also unhoused that are tied into justice-involved populations. Individuals who prefer a language other than English. Unhoused youth came out as a very specific population. And then also medical providers and our coordinated care organizations. And on the coordinated care organization side, we do have processes in place to streamline that process. But I did just want to, say those are specific areas the work group has said community partners are invaluable because of the trust and relationships to help individuals who may not be able to navigate or have the time to call in at the wait times that we know the call center often can be because of that workforce capacity issue.
I feel like I would be remiss to not mention, and I know you're the Oregon Health Policy Board, but we're also talking about health equity. And so when the public health emergency ends, so will the emergency allotments for food benefits. Yes. So individuals who, for example, one individual might be receiving over $200 and they could be reduced to 20, right? That is so significant because those are still very low income individuals. And that is going to have a huge impact too. So additional work that we're doing with community partners is around partnering with food banks and working on making sure there's communications that we're having to support ways to help people be prepared for what will be a pretty substantial change for them. And that, of course, will impact workload as well.
Thank you for that. This is such incredible work in the world that I live in. And so I want to thank you all because I really do understand the tremendous nature of the issues ahead of us. And I have a specific request of the work group. I would like to understand how their work has shifted policy. I think that's a pretty reasonable request, given that they have been enacted and mobilized to ensure that we're recognizing we're up against such significant limitations in structures and in systems that we've built in the past. So what I would like to know is how their voice has really mattered, how their feedback has shifted our thinking as large, complex systems built by rules, and that we can think about learning from that really incredible work. So specifically, the community partners, what have we done to make sure that their bodies of humans that are touching other systems engage this, and that we've got more hands in the body of work, instead of simply relying on, the state and the workforce crisis that we've got in place. So thank you for that. I'm looking forward to reading a little bit more about what exactly that's looked like. Thank you.
Thank you, Brenda. Any other questions before we keep going with the presentation? All right. Jillian, Randy, are you guys up?
That was, excuse me, that was a joint presentation. I don't think we have anything else at this point. And Oscar, since you encouraged everybody to vote, one part that Jillian didn't say is we have requested additional staffing, and so far that hasn't been supported. So any support you want to throw towards the legislature on our request, and of course, as we move through session, will be greatly appreciated. We're way above our staffing numbers at this time. So thank you.
And if there's one thing that I could just add to Randy's comment there, not only was this a joint presentation, this is absolutely a joint effort, a joint workforce. And, ODHS and OHA have come to learn over the years, and it's never been more highlighted than with the PHE that our success is dependent upon each other, that we can't be successful without each other, because we are all supporting the same people who don't care that we are two different agencies. They just care that they need to get their needs met. So I'm so thankful to the partnership that OHA and ODHS have together, and I really believe that's going to make us better able to support people as we go through this.
Thank you, John.
Yeah, so I'm assuming the presentation is complete. It's just so unsettling to listen, to what reality will be for these people. I mean, and I am, like other board members, impressed, and that Oregon is doing this, and people like you all are doing this. But I look at the enormity of the effort that we're making to somehow figure out who's worthy. And it is so sad. It is so sad. It's like COVID created an environment where it was in all of our best interest for everybody to be as healthy as they could. So we turned aside in terms of our concepts of worthiness. And now, we're back to that. And I just think it's so sad. And, I hope that there's an effort to record and document the suffering that will occur as a result of this. I feel bad because I saw a report a couple days ago on income inequality in Oregon, and hear the conversation about income verification for the people who are struggling and the worst off. It just doesn't make sense. It really doesn't. So no questions. Thank you for the work you're doing. It's great that it's in the hands of capable folks.
Yeah, I have a question, and it's similar to Brenda's question about sort of like the infrastructure, right? I mean, this is a huge volume of work, new work, additional work. And we're getting these monthly updates on the unwinding. So I would love, like, for potentially, next month to sort of really focus on these sort of like infrastructure, like that changes that have been done within OHA and ODHS in terms of teams. Like, how are you? It sounded like there was new positions, unbudgeted positions being added, right? And then also like repurposing of teams and reshifting. I would love to to see, what does that mean? What does that look like? As you repurpose teams, what's not getting done, right? So, and is there anything that the Health Policy Board could do to help, not have those be unbudgeted positions, but actually be positions that you need to kind of be able to execute this work better, so I would love to see if there's a specific focus on that for next month's presentation or update.
I think that I could absolutely come back and we could do that. We're contracting to do a workload survey, which will hopefully support our request to the legislature to fund our ability to do this work. And one of the things, though, with a workload survey is that it's impossible to really capture the work that's not being done. But what we can say is we have this much work to do and this much capacity, and we know this much work takes at least this much time. Therefore, there are things that aren't getting done. We are also looking at specific specialized teams that are focused on things like long-term care financial eligibility. There's the able-bodied adults without dependents SNAP that is going to also be implemented and will significantly change workload. We're looking at a focus team on that. So we're really trying to identify who's at the most risk within the structure that we've created within one that is unfortunately pretty rigid, and how can we have flexibility, and how can we meet the needs of individuals that have those additional barriers than what the system's built for. So if that is sort of what you're asking for, Oscar, I can absolutely come back and talk to some of that, and we can talk about how can the health policy board support and help with all of this.
Yeah, thank you. That would be really helpful. And you know, it actually it makes me nervous, right? Like if OHA and ODHS need additional like capacity, like you need that now versus, you know, next year, because in terms of the timeline that I saw, it looks like if we're expecting this to begin in January, and then you have about 10 plus months to kind of get things mostly done. Yeah, like you need that infrastructure like now.
Yeah,
Brent?
just a quick follow-up. Just curious about how many vacancies you're currently looking at to fill within the resources you have already, and what that gap looks like for the call wait time specifically. Yeah.
We're above our FTE authorized for this work. We've authorized almost 1,000 additional positions. So it is unfortunate.
And you've staffed to that level, so those are filled positions.
We're not quite there, and of course it is. Unfortunately, it's always been a portal into the to the agency. We were one agency, and now all eligibility is back on the OHA or DHS side. But so there is some turnover, and probably, as you well know, workforce. It kind of depends on where there are areas that we're still able to hire. There are areas that we're not. The work is virtual and can be done that way, so it's a little bit of a new world. And I do kind of want to put a plug in. I know this is all kind of bad where we're heading. It is historic. It did have about a 34% increase in caseload. Of course, every state is going to be wrangling with this. And of course, we are taking the most positive, as you said, John, keeping everybody eligible. There's some states who are taking very drastic other directions. We're not going to do that. I think it's also worth reminding, we launched our new system during the pandemic. It's only a year and 8 months old, and we made significant changes to it. And actually, the launch went extremely successful, and we did it remotely. To say, you know, it's functioned well, it has. We're making improvements along the way. But to your point, we're above our FTE for this amount of work. Of course, there's vacancies probably here, there, and yonder, but turnover is normal in certain areas. That answers your question, Brendan. But the need projected, again, Jillian mentioned we're going to get a better model. Fairbours and Nate testified, we're about 2,000 staff short of what we actually need. And of course, that wouldn't be a long time need. There's going to be some regular work and improvements we make along the way. We don't want to have that much staff. We want to make the system much more efficient and better and safe for users. That helps a little bit.
John?
Yeah, I mean, Oscar, as I listen to this, you know, might we see what unfolds during the elections and come back in December and discuss how we, the board, could weigh in, you know, because it's kind of like there's a huge fire burning and we need 1,000 more folks on the front lines of the fire, and we don't have the authority to hire them. Because, you know, I guess they'll be suffering if we do this well, but I sure would hate to be in a position of seeing they're suffering because we didn't hire enough people to do it well.
And I know that was to you, Oscar, but I will respond with, we are hiring at the maximum capacity we can. You know, to be honest, of course, we could not onboard 2,000 people. and let alone have them trained and have all the resources and have them up and running by then. So, but all the support, never going to turn away support, John. We do have a policy option package in our agency request budget. Of course, the governor's working on their budget. As you pointed out, we're going to have a new governor and unsure who that is at this point and which direction they might go, but any support would be welcome. So.
Great. Well, yes, I agree with you, John, and we'll know more in the next few weeks. And then, yeah, love to get an updated presentation next month with those particular areas of focus. Any other questions? Sarah, looks like you wanted to say one more thing.
I did. I just wanted to go back to John Santa comment. You made 2 comments back of the impact to those we serve, these 1.4 million individuals in Oregon. And my OMSBUD program every single day receives phone calls from individuals who do not understand what their eligibility is, who have had their eligibility impacted. It is in the 4 years I have been reporting for the OMSBUD program, the #1 reason, Medicaid related concern why individuals come to our OMSBUD program. And I do estimate in general, we receive less than 1% of concerns to the OMSBUD program, appropriately so. So I see our OMSBUD's impact as a tip of the iceberg, not a comprehensive understanding, but a tip of an iceberg, and should be seen that way. But we do have that and see that from the OMSBUD program. Our community partner program sees this daily, as do my innovator agent team, as they are involved in community advisory councils and working with members. So we have anecdotal data, and then also our OMSBUD's reports that every quarterly reporting see that as the largest impact. So I just wanted to flag that, John, as your question of understanding the impact. It does terrify me because I see that now in my OMSBUD's program, but we will have those data at least of the impact from OMSBUD's cases, which is a small percentage.
Great, thank you, Sarah. Any other questions? All right, well, thank you so much for these monthly updates and all the work that you're doing. It's very, very important work, so thank you. We're going to move into our next agenda item, which is about the nursing workforce study that was recently conducted. So we have leadership from the Healthcare Workforce Committee, as well as the Oregon Center for Nursing. We heard last week about this during a webinar. So today we're going to dive deeper into the study, and we're going to have time for OHPB member questions and discussion. So I'll let the presenters take it away.
Perfect. Good morning. Can everyone hear me okay?
Yes.
Perfect. Good morning. Good morning, committee members and attendees. My name is Laura McKean, and I am the Director of Oral Health Services for All Care Health, but I also have the privilege of serving as the chair of the Healthcare Workforce Committee. So we want to definitely thank you for the opportunity to share about this nursing workforce study. And I wanted to just give a brief overview of the project purpose and introduce our presenters this morning. So the Oregon Healthcare Workforce Committee was directed by the Oregon Legislature through House Bill 4003 to conduct a study of Oregon's nursing workforce. And we wanted to identify and describe challenges in addressing staffing shortages in nursing. The work group began meeting in June of 2022, and the study was intended to provide information to inform the legislature and the Oregon Health Authority in their efforts to address critical concerns about nursing workforce shortages. The study considered all levels of care, including but not limited to hospitals, long-term care facilities, community health centers, home health, public health, and schools. Representative Rachel Prusak sponsored this legislation, and we appreciated her support and feedback. So briefly, I'll introduce our presenters this morning. I will start with Troy Larkin. Troy has been a registered nurse for 3 decades. His clinical practice experience includes adult and pediatric emergency and trauma resuscitation, adult critical care, and post-anesthesia care. He holds an associate and baccalaureate degree in nursing, a master's degree in nursing and population-based health, and a PhD in nursing from the University of Hawaii at Manoa, where he studied nursing academic and practice partnerships. Dr. Larkin serves as board member for the Oregon Center for Nursing and is a member of the Healthcare Workforce Committee. We also have with us Jana Bitton. Jana is the executive director at the Oregon Center for Nursing. She began work at the Center for Nursing in 2009 and has also served as a program manager, program director, development director at OCN. She is the past president of the National Forum of State Nursing Workforce Centers, which is a nonprofit providing connection and technical assistance to nursing workforce. She is a native of the Portland area, and Jana holds a bachelor's degree in journalism from California State University and a master's of public administration from Portland State. Jana has a very diverse background in nursing workforce issues, healthcare, workforce development, nonprofit management, and local government. And with that, I will go ahead and turn it over to Troy and Jana.
Thank you so much, Laura. I wanted to, I think this is just a recap of Laura's intro. This was, all right, so thank you. The background, as you know, House Bill 4003, we did contract with the University of California, San Francisco, Joanne Spetz, and with the Oregon Center for Nursing to provide the Oregon specific data and experience. Next slide. The process that we followed was that we formed an advisory group, and the advisory group was led by the Healthcare Workforce Committee. I had the honor to lead that group of 16 members. They were made up of all sorts of interested parties within nursing. So hospitals, healthcare delivery systems. We had leaders from education, professional associations, the State Board of Nursing. We made specific inroads with the long-term care industry and made sure that they were included and at the table as well. So these groups met since June of 2022. And it's the work that they have been looking at that we're going to be presenting today. And I think Jana is up next to provide the conclusions of the report. Jana.
Thank you so much. And actually, for the person controlling the slides, go ahead and hit enter again. The things are, there you go. So we've got the whole thing. So thank you very much, Troy, and thanks, Laura, and thank you, committee. I really appreciate the opportunity to talk about the nursing workforce with you, especially when we think about workforce. It seems like that's come up a couple of times already this morning about the challenges that we have with workforce in our state. And when we think about the healthcare workforce in particular, it's important to remember that the nursing sector of the healthcare workforce is the largest sector. So I appreciate the opportunity to participate in this study. OCN's been working on Oregon specific data for more than 20 years about the nursing workforce, and having this report put together with the work of Dr. Joanne Spetz at the University of California, San Francisco has been amazing. I think the way that we are going to be thinking about this report for the next couple of years is this is the Wikipedia of Oregon nursing workforce. So I'm hoping that all of you can have the opportunity to dive into the report and know that we've got a good handle on what's going on. So I think it's going to come to as no surprise to anyone that Oregon's nursing workforce is severely stressed. I think we've heard a lot of anecdotal reports in the news. There's been a lot of discussion about how Oregon's nursing workforce has been impacted by COVID. But the fact is that COVID and the pandemic actually just exacerbated existing problems. We knew that there was a report that came out in 2020 of a study of nurses in 2019 that showed that nurses were experiencing some pretty severe mental and emotional trauma and stress just from their jobs alone. And it's been a problem within the nursing workforce for a long time, and the pandemic just exacerbated it. Other states are having similar challenges, you know, just like the challenges that we are experiencing with the redetermination that we just talked about. Oregon is not exempt. We are experiencing some of the same challenges as other states when it comes to the stress that is impacting our nursing workforce. We know that there are widespread nursing shortages. There are high rates of burnout. That was happening before COVID. One of the questions that OCN gets asked quite a bit is, what are the rates of nurses who have retired or just completely left the profession? We don't really have that data. We don't really know. We can only work off of the anecdotes that we've received and the stories that we're hearing. And we know that nurses are severely burned out. We know that both nurses and employers are deeply, deeply concerned about this, and everyone is trying in their own way to try to attack the problem, but it's still a problem that we're dealing with. The causes of nursing shortages are going to differ across regions and by type of healthcare system. What that means is that the reasons why people are not choosing to work in nursing in a rural area, those are different reasons than a nurse that's choosing not to work in an urban area. So there's different kinds of drivers for why people are not working there in the areas that they're working. And it's the same thing for hospitals and long-term care, or in home health and hospice, or public health, or some of the other areas that we need nurses to be working in. And as I said before, there's not a lot of data to be able to assess the extent of it. We don't know where nurses are going or where they're leaving. We don't have that data readily available to us. So it's really difficult. And also, as we talked about before, it's difficult to know what jobs are not being done based on the work that's being done by nurses in the state. Go ahead and go to the next slide. So we know that nurse workload is a concern among nurses and employers. We know that nurses are reporting that one of the major stressors that they are experiencing is a really high workload. Now, Oregon has a nurse staffing law that is designed to try to mitigate some of the challenges that were happening with nurses and their workload. It's not really fully achieving its goal of ensuring adequate staffing for high quality patient care. There's a lot of differences in opinion on why this is the case. It's just the one area of agreement is that it's not achieving the goal. There's some concerns about the complexity of the survey that's being put out. There's perceptions that enforcement isn't as rigorous as intended, or isn't applied consistently. And there hasn't been an objective evaluation of the outcomes of the law that was put into place about nurse staffing. Now, keep in mind, nurse staffing laws apply to nurses that are working in hospital settings only in the state of Oregon. That accounts for about 55% of the nurses. So when we talk about workload and the staffing law, we're actually talking about half of the nursing workforce, and what what Oregon has tried to do to mitigate the stress that's happening there. The national data indicates that in Oregon, in our hospitals, we have higher nurse staffing than the national average, but is that enough? We're still getting reports of nurses being stressed because of workload. So even if Oregon is higher than the national average, that doesn't necessarily mean that that our nursing workload is okay. Go ahead to the next slide. We also, when we think about, go ahead and just do all of that. Perfect. When we think about the nursing workforce, not only do we need to think about how many nurses we have and how many nurses we might need and what the challenges are that they're experiencing, we also need to think about the pipeline, and we need to think about who's in nursing school right now. So we know that the growth in new enrollments in nursing programs has slowed over the past 3 years. We have a lot of evidence, and also LPN enrollments have declined. We have a lot of evidence for why that is. Which is the next bullet point. They struggle to grow because of the difficulty in recruiting faculty and finding clinical placements for students. Those faculty shortages are attributed mainly to low salaries for nurse faculty compared to clinical salaries. And there's a lot of information in the report that kind of sparses that out so that people can understand that faculty, in fact, that if you're a nurse faculty in our state and you have an education that's a master's degree or even a doctorate degree, you could be making up to about 40% less than what a similarly educated nurse is making in the clinical space. So as long as we have this massive disparity between pay, it's going to be very hard to encourage and entice nurses to work as educators. And as long as we don't have educators, we're not going to be able to grow the capacity of our programs. At the same time, the way that we educate nurses right now is we have these in-person clinical experiences where we put them into a hospital or a long-term care setting so that they can have that in-person clinical time to practice their skills. Those are called clinical placements, and those clinical placements, there's a limited supply of what that can be. During the pandemic in particular, and particularly in urban areas, in the Portland metro area, a lot of clinical placements were cut in order to be able to save on PPE, be able to save on the stress of nurses. There's a lot of, and some of those have come back and not all. We also know in the state of Oregon, our applications to our nursing education programs have actually declined over the past 4 years, but we don't really have a good idea about why that is. That's not true in other states. In other states, nursing education programs have increased over the last 4 years, but not in Oregon. We have some hypotheses, but we really don't know. We don't have good evidence as to why. Good. And then finally, the last thing, Oregon is heavily reliant on nurses that are educated in other states. In the state of Oregon, we educate and graduate about 1,700 nurses, new nurses every year from our nursing programs. The Oregon Employment Department, however, is forecasting that we're going to need about 2,700 new nurses every single year to make up for retirements, to make up for job, and also to make up for the demand for services. So we are about 1,000 human beings short in the state of Oregon every single year to meet our demands. Right now, we are making up that we are filling that gap with nurses coming in from out of state. So right now, we don't have a gap in the number of people. What we do have a gap in is just that's a pretty fragile reliance on nurses that are graduated from other states. Go ahead to the next slide. And when we talk about diversity, and especially with the goals that we have in our state for health equity, we need to also take a look at the diversity of our nursing workforce. We know that our licensed nursing workforce population is not as diverse as the state's population. And in the 12 years that I have worked here and worked in Oregon and in nursing, it has not been so. We know that the current nursing student population more closely resembles what the ethnic and racial diversity is in the state. However, it's kind of a drop in the ocean. If we're graduating about 1,700 nursing students a year, and we're putting them into a licensed population of about 80,000 people, it's going to take us a really long time. It's going to take Oregon a very long time in order to start changing that demographic. It's happening. It's just not happening at the speed at which we probably would prefer. We know that in Oregon, our CNA and LPN workforces are somewhat more diverse than the total population of Oregon. We know that our registered nurse and nurse practitioner workforces are less diverse than Oregon's populations, but we know that RN students have become more diverse over time, and that LPN students have also become more diverse over time. So that kind of is the sense of when we're trying to talk about diversity in our nursing workforce. We are doing it. We're getting diversity to a point. We're getting more diversity in our nursing student population, but that is going to take some time to move into the general population. And because we're reliant on nurses coming in from other states, we're also reliant on the diversity of other states and their plans for educating more diverse sets of nurses. I think that that's all of our conclusions. Those are the main highlights. And now for the recommendations, I'm going to turn it back over to Troy. He can tell you more about the recommendations, and then we can answer questions.
Thank you so much, Jana. So recommendations, we have broken the recommendations down into 9 different groups. And the first group is really about workforce retention. And I'm really happy to see that this is our first recommendation that we're presenting, because this is where a huge amount of the problem lies. And we are not going to be successful in having a robust nursing workforce within Oregon if we don't stop the outflow. And the workforce retention recommendations are really all around trying to keep nurses in the positions that they're in or within the nursing community, and to not leave that community within Oregon. And first and foremost, the mental health and well-being of nurses really needs to be prioritized and supported. There are many employers who are making good faith efforts in this space. It is challenging because there is not a single recommendation or two that if you just do these things, it will help the workforce. This is an iterative process, and we are finding out as we go what are the things that are most impactful for nurses to continue within their employment. And we know that employers have to create those healthy work environments to support health and well-being of their caregivers. The government can help support those employer efforts by expanding, maintaining the Oregon Wellness Program, helping incentivize businesses to do the right thing and improve the workplace health, and developing robust programs, seed funding for innovation in this space. So step number 1, stop the outflow. Next slide. Our next is to look at the education pipeline. And this is really building on much of what Jana said. But even before people are applying to nursing school, they need to know that nursing is a great field, and it's an area that they can see themselves in. And if you're a man, if you're a person of color, can you see yourself as a nurse? So prioritizing that K through 12 particular recruitment, particularly from students from socioeconomically disadvantaged backgrounds, to help support mentorship, creating shadow opportunities, so that things that happen in clinics, things that happen in nursing homes and hospitals really aren't shrouded by the front door. And this is getting out in the high schools and the post-secondary education institutions so that people can be successful. And then when you do recruit somebody, especially a person of color, a minority, a man into the profession, do you have supports for them in school, so that not only is it a recruitment, but it's a support after the recruitment piece. And so many of the recommendations around education pipeline will definitely help increase the diversity within our nursing communities and make sure that we have people applying to the very rigorous nursing programs that we have. Next slide. The next really is around education capacity. And we know that there are education capacity restrictions within nursing. Even if there are less people applying to nursing school, it is still a very difficult program to get into. And we can make that better if we have more programs. This is especially true if you're trying to get into a program as maybe a part-time program or into a program that's in a more rural setting. If you're not willing to quit your job and work and go to school full-time and do it in an urban center, chances are you're going to have a real barrier in becoming a registered nurse. So we want to take those barriers away by expanding RN education capacity, especially in the rural areas. Look at laddering programs from CNA to LPN, LPN to registered nurse. So students experience that as it is kind of a seamless education trajectory. We want to make sure that we're sharing faculty, because Jana pointed out, there's not enough nursing faculty, and we need to be able to spread them across programs as much as we can. Oregon has been in the forefront with OHPB program, which is setting basic standards within undergraduate pre-licensure education and making sure that Nursing 101 at College A is very similar to Nursing 101 for College B, and increasing support student services for RN students, especially those first generation college and underrepresented institutions, we think government can help by making sure that there are supplemental salary strategies and policies such as tax breaks and loan repayment. Next slide. So clinical experiences, Jana touched on the challenge of clinical experiences. And I will say in my position with Providence Health and Services, I see this all the time. The hospitals, as we have increased turnover, as we are filling positions, we use people, our caregivers, to help orient and precept new people, especially those that are new to nursing, and that can be very intensive. Those are the same people that are also welcoming students and working with those students so that they have really some on-the-job training as they go through their nursing program. So as we are tighter in our labor markets and we're spending more energy in onboarding, that is a pressure against accepting more students into the precepted program. So that dynamic plays out in Oregon all over. And we can do a better job by being more organized about how we distribute this clinical placement with centralized clinical placement services. We have that to some degree in Portland, but it doesn't exist in areas outside of the Portland urban boundary. We need to have more simulation experiences, and we need to have faculty that are really prepared to do a great job with simulation experiences. Apprenticeships, internships, residencies, all of those things are needed. And the Oregon governmental agencies and employers need to strategize to fund these types of programs. So it's not just the school or the student or the healthcare institution that's taking the financial hit, which is often productivity and time with the patient. So we don't take this time away from the patient that needs the caregiver to provide it to a student. The nurse intern licensure regulations need to be evaluated, and innovation encouraged to optimize their use. This is where a nursing student can come and work in a healthcare institution while they're going to school. They can make a big contribution to the care of patients and also reinforce their learning, but that program needs to be solidified with the way that it's operating now. We're also encouraging elective courses with the nursing programs. Nurses are all prepared as generalists. And we don't recommend changing that, but we do recommend having some opportunities for nurses in school to get some of the specialized education that they need to work in things like obstetrical units or critical care units. Next slide. So this is two recommendations on one slide, and this is to take a look at how we look at certified nursing assistants and then the nurse licensure compact. So a certified nursing assistant in Oregon, it's fairly complicated. There are two different levels, a CNA 1 and a CNA 2. To the best of my knowledge, North Carolina is the only other state in the country that has a two-tiered CNA program. To some degree, it's created some confusion, and the Oregon State Board of Nursing is encouraged to kind of examine and simplify this. We also want to make sure that we're looking at the length of time that it takes to become a certified nursing assistant and make sure that Oregon is not outside the parameters of what other states are doing. And right now, our hours are on the high side. For nursing licensure compact, a lot of people in our interviews and in the surveys that we were completed pointed out that, boy, the nursing licensure compact could solve a lot of problems. We do believe that it can solve some problems, but it also raises some problems. And we do believe in looking at the survey results that people are overestimating just what the nursing licensure compact could mean. So we want to encourage a thorough exploration of the nursing licensure compact and to make sure that we're being realistic about what it does and what it does not do. There are some very good benefits out there for licensure compacts. This is allowing a nurse from another state who's licensed to come into Oregon and not have to go through the same hoops for that initial licensure. But one of the things we're going to lose if we do this is a loss of data on the nursing workforce, and to some degree a loss of funding for the Oregon State Board of Nursing that gets much of its funding through the licensure fees. Next slide, please. Janet touched on the Oregon nurse staffing law, and we do need to objectively evaluate its impact. It was designed to do some things like improve nurse staffing and improve workload and improve nurse satisfaction. We would really like to know if it's doing that or not. And there's not good empiric evidence that it's doing that, but there's not empiric evidence that it's not doing that. We simply don't know. So we would encourage some study on this area. We heard through our interviews that there's a need to improve clarity, really create supportive partnerships, and reduce unnecessary regulatory burden. There were issues around the surveying process and making sure that it's consistent, that organizations know how to comply, and that there is more structure, I guess, around the idea of acuity and how do you measure patient acuity and what the resources are really needed for each patient. That brings up, California as an example of a state with fixed minimum staffing ratios. Have that conversation with realistic understanding about the benefits and drawbacks of those programs. So we do encourage a revisiting of the nurse staffing regulations. Next slide. We also recommend local solutions to shortages. So Oregon's policymaker and healthcare employers should support market research to understand the local barriers to nurse recruitment and retention, because the challenges in an urban area such as Portland is very different than a more rural area like Gold Beach. So we need to know what the data is across the state because it does not look the same. Looking at just a number of nurses is insufficient to really understand, do we have people specialized in the right areas and do we have them prepared at the right levels? And are they distributed around the state in the areas that they need to be? We know that acute care and long-term care, there are big gaps in those two practice areas, just as an example. So for our rural communities, we heard many stories about nurses accepting positions and then having to back out at the last minute because their spouse, their partner were not able to find a job in the more rural communities. We've also heard that same story about housing, especially in the southwestern portions of the state, of just how difficult it is for people to find housing, even though the salary for nursing is pretty good. Both rural and urban communities need to explore reducing the cost and increasing the supply of housing so people can move into these areas where nurses are really needed. Next slide. And then anticipating our future choices. So data and the work of institutions such as the Oregon Center for Nursing. In all transparency, I am a board member of that organization and work with Jana regularly. But I do want to explain that work is so critical to understanding the nursing workforce within Oregon, making sure that our educational institutions understand what's going on the horizon, that our hiring institutions, our healthcare institutions can kind of predict what's going to be happening in the nursing workforce, especially those areas, those institutions that don't have their own workforce centers within their organization. So we need to regularly collect these data on vacancies, and then importantly, the perceptions of the local labor market. Numbers are one thing, but the lived experience of this is another altogether. Developing data systems that support more detailed projections of future nurse supply and demand is really important because it's not just about the number of nurses, it's about the need for nurses within our healthcare institutions. And changes in our demographics, getting an older population, having more and more nurses retire, all of those things impact that. and then invest in identifying and understanding the root causes of racial disparities in the nursing workforce. We need to emphasize successful strategies to expand opportunities for our marginalized populations and involve workers from these communities so that we are getting the voice of all of our communities together to build a workforce that works for Oregon. I believe this is the end of the slides, and I'm very happy to sit with Laura and Jana and accept questions from the committee. Thank you so much for the opportunity to present.
Thank you so much, Troy, Jana, and Laura, for the great work, the case study, the reports, and the presentation. Do we have any questions from board members? Brenda.
I love this body of work. So to all of you, thank you so very much. It is so comprehensive. And it, I think, is really on the money. Like, it just really points out where some of our most critical deficiencies are in this part of our really critical workforce needs. With such a comprehensive report, I have a question, and not to put you on the spot, but to request this perhaps go back to the Healthcare Workforce Committee and to this board, which is, if you were to help us prioritize the first 3 highest, most critical recommendations that this board could help track, lift, understand, you know, kind of be closer to, and then the next 3. I sometimes recognize it's hard when there's such a big body of work to really focus our efforts and our intentionality. So if you were asking us to keep our eye on and our attention on specific recommendations, what would those top 3, that first top 3 be? And then the ones right after that. So again, no need to respond to me. It's just a personal request, you know, that I think could help in our Healthcare Workforce Committee role as a liaison. I think personally, I would love to stay close to it, and then for the board overall.
Yeah, so Brenda, that really resonates with me, and I'm not going to take on what, you know, Troy's top 3 and Troy's middle 3 options are, but I think any guidance that you could offer on, you know, there's impact, and then there's ease of implementation. And sometimes doing something that's not the most impactful, but it's something we can do tomorrow, makes that a more important recommendation. So I think wrestling with just purely what's the most important, and then I don't know if realistic or what are the first ones to implement might be something we also think about.
Laura?
Yes, thank you. Thanks for all the work, everyone. And, you know, I would be remiss if I did not thank Brenda as our liaison for all of her support. She's our Healthcare Workforce Committee liaison. You know, I don't know if anyone had the opportunity to attend the State of Reform conference last week, but workforce was the huge topic of discussion for most of the entire conference. I had the opportunity to sit on a panel with three folks, one of them being Representative Nelson, who's very passionate about the nursing workforce. But, you know, I think that we struggle, and what I've tried to encourage folks and the Healthcare Workforce Committee is to try and think outside the box. What can we do to support this nursing workforce? I have a friend that is attending Road Community College. They would have many more students than they have now, but they cannot afford to pay the faculty. You can, as Troy said, you know, you can go to the hospital and make $30,000 more than you can as an instructor with a master's degree at the college teaching nursing. So I just think we need to think outside the box and see how we can support this this workforce in maybe a different way. But thank you, Troy and Jana, for all of your hard work on this.
If I get a say in this, which I hope I do, I think you kind of need to look at it, like Troy was saying, it's like you kind of need to look at what can you do right now and what do we need to do so that we can help this in the future. Right now, we need to do everything we can to keep the nurses that we have working in the profession. They want to. a lot of the ones that have burned out, they haven't left. We actually did a study and saw nurses don't give up their license, even if they're burned out. Honestly, even if they retire, they don't give up their license and say, I'm completely out and not going to be a nurse anymore. Generally, what they'll do is reduce their hours. They'll suddenly start needing to work 1 day a week. They'll, they'll just be on call. Some of them will be travel nurses and they'll leave the state because they can make so much more money. I think the number one thing that we need to be thinking about as a state for the immediate term is how can we retain the nurses that we have? And then secondly, we need to understand how can we grow and make sure that we have the nurses that we need. That really speaks to the education part of it. If we just keep talking about shortages and how we have shortages, we're really not going to be addressing the problem, because we've been talking, I mean, we found a document from 1959 from the Oregon Nurses Association talking about the shortage of nurses. This is not a new problem. We have to be very innovative in the way that we look at it so that we can make sure that we get care for all the Oregonians that need care when they need care.
Yeah, I just really want to appreciate like the Wikipedia as it was referred to today by Jana. I thought it was really great to sort of like, see some upstream recommendations as well. I really enjoyed the recommendation about getting the educational system involved a lot sooner. One of the thoughts I had about that, particularly as we're trying to also talk about diversifying the workforce, is making sure that we go beyond just the mainstream K-12 public school system, but that we're also looking at alternative, educational programs, community-based programs, culturally specific organizations, because they're serving a population that's also much more diverse. So being able to include that as partners in this work. Any other questions from board members about the report? Melina.
Yeah, hi, thank you. As a nurse myself, I'm very interested in this report, and thank you. I love how it was all encompassing your recommendations, keeping the nurses working, how to train the nurses, and I really like how it encompassed a lot of different areas. One thing I'm just wondering about is I heard that the graduation, we graduate 1,700 nurses a year. We get another 1,000 from out of state. But what is the current and then projected nursing shortage in Oregon? Like I know there's a nursing shortage. There's always a nursing shortage, but what does that look like in numbers and with the aging population, it's going to grow?
Well, I can take that. There's really no way to say. We know that there is a nursing shortage. We know that. You can feel it, right? When you go into if as a nurse, you can feel it because of the work that you do, and you know that your workload has increased. As a patient, you can feel it when you have extremely long waiting times in emergency room visits, or it takes months to be able to get into any kind of just regular routine care. But really being able to say we are short this many people, we can say that. Like, we could say that. I could actually tell you that according to the numbers that we have, we don't have a nursing shortage. We have a surplus. We have more nurses than what the demand is, and that's based on the number of nurses that are coming in. But that doesn't actually, there's cognitive dissonance with your actual experience. And that's kind of what we were trying to get with this report, is that if you just look at the number of people that are coming in and the number of people that we're producing and the number of people that we expect that we're going to need, it's not going to tell you the story. You're always going to have shortages. You're going to have shortages in rural communities because spouses can't get a job, or there's not enough economic services that are there. You're going to have shortages in specific areas in urban settings, and you're going to have shortages across the state when it comes to housing. You're going to have shortages in long-term care because they pay differently and it's different work than what you could get in acute care. And you're going to have shortages of people not wanting to work in education because of the pay disparity there. So it just is so nuanced that you can't just, we need to, as a state, move away from the concept of, are we making enough? Do we have enough? And are there more people coming in to fill the gaps? Because the answer to that question is yes. But if you just throw your hands up and say, oh, well, we're good, then that isn't reflective of the lived experience of almost every nurse across the state right now. So yeah, it's not a numbers game. It's not a numbers game, and everything is connected now, right? Like, and I think that that's something that's new. Like, who would have known that graduation rates from public schools would actually impact our nursing workforce? Or who would have known that our housing, the crisis that we have about housing, that's a factor within our nursing workforce. Those things were kind of outside of the scope of this particular report, and yet they still need to be considered if we want to make sure that we have a stable nursing workforce to support the healthcare system that takes care of everybody. Which is so complicated. That was probably not the answer you were hoping for, Melina. I'm sorry.
No, that's okay. It's very complicated. And, looking at nursing vacancies at hospitals or long-term care facilities, I mean, you could see how many vacancies, there are. And with, it kind of goes into the staffing law too. If you're going off of acuity or number of patients, it's different if you're in the ER or if you're in a long-term care facility, and then it's not being enforced. So there's, I'm really glad you did this. Yeah.
Yeah, thank you. And it is important to remember, this kind of goes to the last recommendation that was talking about data collection. We do not have a statewide systematic way of collecting turnover or vacancies. The Oregon Center for Nursing has tried to do it, but it's not required by the state. So we generally have to do samples. And when we do samples, we can get a general sense of what the state looks like. But unless everybody reports that data in, then we can't break it down regionally. We can't break it down. We can break it down by setting somewhat. But that's one of the parts of the recommendations, is really need to look at where are those data gaps to make sure. And if there's something that the committee could do, not just this committee, but the state, if there was some kind of statewide initiative about collecting vacancy rates and turnover rates in the different settings, that might give us a better picture of what the workforce looks like.
John?
Yeah, I think I made this comment, I think at the educational seminar. I think you could identify ways in which physicians could be more supportive and helpful. I practiced part-time much of my career. I couldn't have done it without a nurse being there when I wasn't. Couldn't have done it. And there's a lot of physicians who practice part-time who are in the same situation. They need good nurses. Now, sometimes a CNA can do it, but in other practices, you need an LPN or an RN. And, I think of many of the surgeons who, years ago, they would have their own dedicated nurse that they would hire. I think as many of those surgeons are employed by hospitals now, that becomes a hospital employee and maybe the link isn't as strong. Or, heart surgeons, the quality of their lives depend on incredible nurses in the ICU who really are the equivalent of doctors. They manage those patients, and the heart surgeons would have a terrible quality of life if they didn't have a steady supply of incredible nurses. And maybe there's strategies that Oregon's physicians could help with in a variety of ways that you could figure out.
One other comment just from me, a thought from the report. I thought that, you know, I think as we try to diversify the workforce, it was interesting to see that within CNAs 1 and 2s, that's where a lot more of the diversity in terms of workforce is concentrated. And also it seems like that's where the younger, you know, sort of workforce is concentrated as well. So I think you alluded to this in the case study, but I just love to see like a very intentional recommendation about like sort of setting the stage for those to move forward in their profession, and to be able to actually have whether it's incentivized programs or that kind of get them moving into becoming an RN or moving forward. So are there any other comments or questions from the board? Well, I'm really looking forward to having this presented to the legislature next year, and would love to continue hearing progress about this. And I'm sure your fabulous liaison, Brenda, will keep us informed of this work as it moves forward next year. So thank you again so much for all your work on this study. We are going to go into a break, and it's 10:20 now, so we'll come back in 10 minutes. So we'll be back at 10:30. To the second, welcome back to the second half of our meeting. If I can just, if our fellow board members could turn on their camera just so that I know that they're here, or give me a thumbs up. We're going to get started with public testimony. And Jessica, nice to see you. I believe you've been in the meeting, you've just been on the phone, so it's great to have you.
Yes, thank you.
Okay, so we are going to move right into public testimony. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it in fully into our awareness, understand it as an important consideration for our work, and listen with the thoughtful attention, respect, and honor that you deserve. Public comments are meant to provide everyone an opportunity to share their perspective and be heard. However, public comments are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and if that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public speaker. And I believe we have Tom Bussey signed up to provide public testimony. Tom, are you here?
I am.
Great. Please begin when you're ready.
Hello, my name is Tom Bussey. This is Micah. Happy All Saints Day, and I'm the congressional candidate for the Libertarian Party for District 1. The audited financials of the CCO Care Oregon revealed in fiscal year 2021 that gave away $11 million in taxpayer dollars to community grants. This is up from $300,000 3 years ago. They failed to follow the public records law, and they refused to give me a list of their fiscal 2021 grantees. They also stopped publishing the information to their website. Is there any oversight of the slush fund? Is this where the Wealth Authority hides its dirty work? How do we ensure that these funds are not used for inappropriate purposes? This is a giveaway to crony special interests in the nonprofit industrial complex. They indicate they sponsor fundraising event, an opportunity for executives to hobnob with big pharma co-sponsors. I think the bulk of last year's gravy train was used to buy the silence of nonprofits willing to throw their constituencies under the bus when they failed to criticize your harmful and toxic policies, including a vaccine mandate that murdered my niece. You have blood on your hands, Patrick Allen. In one case, I learned of a care organ grant via a press release. They claimed they spent $3 million to buy 20,000 doses of Narcan. There are no prospective randomized controlled trials to show that this might cause net benefit to a community. It's unscientific. And if you do the math, that is $150 a dose on a product that costs 50 cents to make, and I can go to my local Walgreens and spend $40 on. This taxpayer-funded grant completely sidesteps the elected policymakers and the public input process. It's a waste of taxpayer funds that is pure profit for a company called Emergent Biosolutions, which manufactured that death shot that killed my family. You people are evil, and this needs to end.
Thank you for the testimony, and we will follow up. We are going to move on to our next agenda item, which is a presentation on the Healthcare Workforce Committee proposed membership slate. We have OHA staff Mark Overbeck and Stacy De Leon Davis here to describe the new approach that they use to recruit new members, and which is based on recommendations from our committee membership work group and final report. So welcome, Mark and Stacy. Please begin when you're ready.
Thank you so much, Mr. Chair. My name is Mark Overbeck, and I'm here. I use he, him pronouns, and I'm here today in my capacity as the lead staff for the Healthcare Workforce Committee. And I'll invite my colleague, Stacy, to introduce herself.
Hi, everyone. Stacy De Leon Davis, she, her, ella. I guess I'm a representative of the committee membership work group, which is led by Susan Otter, and there are multiple members, but just to name a few: Tara Sheetalk, Jeanette Taylor, Katie Howard, and Stacy Urban. And so I'm just one of the many who help do all of this work.
We're very happy to be here with you to speak about the process that we followed and the outcomes that we've achieved in using this new process for recruitment for the Healthcare Workforce Committee and other committees of the board. So if we go to the next slide, we'll start down the road with that process.
So this is the recruitment process from start to finish that we have developed, and I speak we as the committee membership work group. There's 4 buckets, right? So we have the pre-recruitment activities, the application, choosing members, and then the roster approval, which is what we're seeking today. And under the pre-recruitment activities, we have the committee composition, which we will talk a little bit about the gap analyses tool that we used. And then 1-pager committee descriptions. That's kind of highlighting the who, what, where, when, how about a committee and why you should join. And then the application process. So really developing that work plan and that timeline. And for Mark's specific purposes for the Healthcare Workforce Committee, it's really looking at working backwards from today's date, because we have to present the slate today. So working backwards from there. The recruitment goals, and then looking at the application and also notifying communities, including the tribal affairs. And then choosing the members. We talk about the scoring rubrics, which we're probably going to rename to scoring metrics just to streamline efforts, equity-based hiring practices, and establishing a review panel and process. And then today we're going to really focus on the roster approval and making sure that you have everything that you need for slate templates around all of the different processes that we have for the 11 committees of the board, and then also those approval and denial letters for candidates.
Great. Thanks, Stacy. And I'll just add, to some extent, there may be nothing so powerful or effective as taking a process that's been well developed and actually staying true to that process over the course of time, even though there may be familiar activities or, oh, we used to do it that way, but actually staying true. So we've got these 4 steps, and it could even be like, you know, you got the box step like 1, 2, 3, 4. And we really did endeavor to stay true to this newly designed process. And I think came up with what we hope you will find to be a really outstanding outcome. So in terms of the pre-recruitment activities, first, we used the committees of the board survey that all committees of the board took, I believe, early this year, perhaps late last year, to take stock of what was the existing membership of the Healthcare Workforce Committee. I think the committee should be proud that 100% of the committee members who are members at the time of that survey did complete the survey. And then from there, we used a gap analysis tool, which had also been developed generically to be able to be used for any committee of the board. If you go to the next slide. Thank you. And when we looked at the time when we began this about 8 months ago, we saw that the existing membership composition based on the survey that all members filled out was almost 2/3 of the members of the committee were white, non-Hispanic, and you can see the pie chart representing other identities for race and ethnicity. And that's where we began. You go to the next slide, please. The gender breakdown of the committee at the time, a little bit more male than female, not too big of a disparity, but 53-47. We also did some breakdowns by profession and sector. Not quite half of the members at the time represented providers, hospitals, clinics. 29% represented some aspect of public health. Near a third were within research and academia. I had 2 members from payer groups, the CCOs, the DCOs, and then finally 1 member representing 6% from what was determined as a community-based organization. And that was our baseline, and that's where we started.
And Mark, if I can just add here, this may not total 100% to you all, and that's because there's a lot of intersectionalities, and we were able to make sure to capture all of that here.
Great.
All right, and then with that information and completing the gap analysis tool, we were able to identify some gaps. Some of the big gaps that we really wanted to focus on were around the geographic and the regional area. So Central and Eastern Oregon were missing. And then also the race and ethnicity. So we had Black and Latino, Latina, Latinx representation missing as well. And when I say missing, I'm really saying we could use more, right? We could always use more. We can always do better. We can always improve. And then we have some gaps with the youth, and there's a note that says disclose student members, because we do have capacity for youth. I say we, sorry. The Healthcare Workforce Committee has capacity for youth to have a voice at the table. However, they are not non-voting members.
Great.
Direct service providers and then community members receiving direct services, long-term care facilities, or providers, non-licensed healthcare professionals. So really thinking about those professions around community health workers or traditional healthcare workers, and then other languages spoken. Oh, I guess we were really passionate about youth because we have it here twice. But maybe this, I think we we were supposed to have labor relations and union representation here as well.
We'll go to the next slide, please. Thanks. So, all of that was step 1 of the dance, the pre-recruitment activities, and then on to step 2, the application. We kept the applications open for a 6-week period between August and the end of September. We sent multiple calls for applications in a special newsletter from our office that has about 7,000 individuals and organizations that subscribe. We did some really deep work, I think, in distributing the call for applications to various partner organizations around the state, and also within the public sphere, requesting assistance if you know someone with lived experience, with health equity experience, somebody who's a great leader in their healthcare related organization, we'd love to consider them. And we also, of course, communicated early and often with our Tribal Affairs Office on the process and as the recruitment unfolded. So that was step 2. And then step 3, in terms of the choosing of members, we did get the applications that we received. Stacy showed the fairly long list of gaps that we were beginning to look at. When we looked at the applications that we had, as Stacy referenced, we used a rubric that really prioritized, first and foremost, experience with health equity as one of the priorities of the board. Lived experience, so that the members of the workforce committee, when they're holding discussions, when they're considering topics, when they're considering recommendations, are able to come from not just something that's academic or superficial, but from their own real lived experience, maybe not being able to access health care so easily, their own lived experience as a human being, and where they've not had the experience of privilege. We obviously wanted to prioritize geographic representation, and as we'd mentioned, race and ethnicity also ranked at the top of our scoring priorities for reviewing the applications we got. Next slide. The review group consisted of Stacy from the committees of the board work group, myself as the lead staff for the committee, and our colleague Terrence Saunders, who's the Behavioral Health Workforce Equity Coordinator within the Health Systems Division, and serving in an important role with the Behavioral Health Workforce Initiative. Next slide, please. Great. So that's steps 1, 2, and 3. And then today's requested action is the roster approval. And before we hear discussion, I'd like to go just for a moment. There's another document that the members received in your packet that actually identifies 7 new members that we're requesting you appoint, plus 3 members who are eligible to return for another full 3-year term to the committee that we're requesting you reappoint. And let's see, can we get that slide deck, maybe the last page of the second document, up on the screen? And if not, that's okay, I can speak to it. While we're looking for that, I'm really happy to say that this new committee roster, should you approve the slate, certainly represents the most diverse and balanced committee on record for the Healthcare Workforce Committee. We will have 3 of 18 members from education, that's community colleges, 4-year institutions, graduate institutions. 10 of 18 are providers, most of whom are currently serving patients in some capacity. Service providers, we have 6 service providers out of 18. That's a third, representing hospitals, federally qualified health centers, and tribal clinics. And CCOs, DCOs will retain 2 members with the slate, plus many other members who are currently serving on either the board of a CCO or a CAC for a CCO, Community Advisory Council. I know that kind of in the Western linguistic sphere, our eyes tend to go to the top left. I want to actually point the members of the committee to the bottom right, where you can see this new slate will include a group of individuals, more than 2/3 of whom have direct experience, as they identified, with health equity, and nearly 2/3 have identified direct lived experience and cross-cultural experience. And you can see the subcategories below there. And that's the bottom right. Moving over to the bottom left quadrant, you can see what we've done is we've identified a group of individuals in total who represent the state geographically pretty well. The Portland metro area is represented in direct proportion to its population, but if you combine the Portland metro area and the Valley, that's 70% of the state's population. However, just over 60% of the membership of this new committee. And said another way, that the 30% of people living outside of Portland and the Willamette Valley will actually have 40% of the membership of the Workforce Committee. We do have individuals who've identified having a disability that we're recommending to serve on the new committee. And if you go up a little bit to the very top, the upper left quadrant, you can see for yourselves how the self-identified race and ethnicity information for the new membership compares in reflection to the state population and also the population of the state served by public sector programs. So one call out is that the new committee, 50% of the new committee would be white, non-Hispanic, and you can look at the various additional race and ethnicity identifications. And as Stacy mentioned earlier, this does not necessarily roll up to 100% because of some intersectionality. I think I will stop there and see if members have questions or comments for either Stacy or for myself.
Thank you so much, Mark and Stacy. And if we can stop screen sharing for just a second. Thank you so much for the intentionality and thoughtfulness and attention that went into the recruitment of the new Workforce Committee members. It's great to see this really this progress in terms of being able to recruit members that represent all areas of Oregon and that have lots of experience and also that make up such a diverse demographic. So curious to see if folks have any questions, thoughts. Brenda, you're the liaison. Can I put you on the spot?
No, I feel like I'm talking a lot today. I am also super grateful, Oscar. I would just echo your sentiments about the quality of the work that this committee and our leadership has put together to bring this slate to us today. I'm also struck by the intentionality of doing that really by the notion of creating relationships and being the kind of a committee that people in Oregon want to join. You know, we are talking about busy people at really stressful times in our environment, and that this committee has positioned itself, I think, to be a standout in welcoming and in understanding how the inclusion of diverse perspectives, belief systems, parts of the healthcare workforce, the mechanism of those conversations to be included is really well done. So that's a tribute and hats off, I think, to our teams. And I'd like to move that we accept a slate of candidates. Yeah.
Great. Is there a second? I'll go ahead and second that. Open it up for additional discussion. Yeah, go ahead, Stacy.
Sorry, if I can add, just to piggyback off of what Brenda said, to really make this process work around recruitment, just to let you all know, Mark and I have been in conversation since June. And so having that application close at the end of September and then having all of the month of October to work on this, that's a 4 to 5 month process to really make something very intentional work. It's a lot of effort. Mark and the committee is kind of seen as an early adopter, so to speak, because a lot of these pieces have not been fine-tuned. So it was really nice to be able to work with the committee and to offer up like some of the gaps and to be able to receive that feedback around what we're looking for. So I just want to say thank you for being open to that and giving us the feedback, because I feel like that really made the recruitment process a little bit more intentional.
Well, I have to express my appreciation for my colleagues with the opportunity to learn and to be supported in going through a very new approach to this. Thanks, Stacy, and to Terrence.
John?
Oh, I just wanted to note how much has changed in the 5 years that many of us have been on the board. and this process is a real indicator of that. And kudos to everybody involved, but looking forward to this becoming the norm. So just impressed with how much has changed.
Great. Any other comments? Well, I just want to say, it's very impressive to see all the percentages and the numbers, and they're all trending in the right direction. And in addition to that, I was able to see the bios of the existing and the new committee members. And these are incredibly talented, leaders and community members and dedicated folks who are going to help us tackle some very, very complex challenges in the workforce. So all those in favor of approving the Healthcare Workforce Committee slate, please say aye.
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 Anybody opposed? Anybody abstain? All right, that is approved. Congratulations, Mark and Stacy. Thank you so much for all your work in this. So, all right, next agenda item is a follow-up from a request that we had last month around the progress of CCO 2.0. So I believe Dave and Krista Mars are going to be here to talk us through some of these updates. Take it away.
Thank you, Oscar. So this is Chris DeMars again. Happy to be here. I'm the Director of Delivery System Innovation, and I'm going to be kicking us off and then passing it over to Dave Inbody, who's the CCO Operations Director. So next slide. So today we're going to be providing an update on the Oregon Health Policy Board recommendations for the current CCO contract, otherwise known as CCO 2.0. So I'll be talking about the kind of overall purpose, and then we'll provide an overview of the policy development process, which is especially important since only about half of the policy board members on today were involved in that. And then we'll be providing an update on key findings from the policy recommendation tracker, and then we have some questions for discussion. Next slide. So just to give a little bit of context before getting into the purpose, in 2017, 2018, the Oregon Health Policy Board was involved in setting expectations for CCOs and developed a final report with 43 recommendations for the next CCO contract, or CCO 2.0. And so, as I mentioned, some of you were here and some of you weren't. Those that were around for the CCO 2.0 policy development process, I believe, were John, Oscar, and Brenda, and also Kirsten, who's not here. So we want to provide kind of an update for you all on the comparison or assessing the original Health Policy Board vision with progress CCOs have made. We want to kind of share whether CCOs are moving in the direction the Health Policy Board intended, and then also looking toward the future, set the stage for the next CCO contract procurement and get input from you all as to how this information can help inform the next contract. Providing a little more context is that we are currently about halfway through the contract, a little beyond that, but this information is from 2020 through September of this year, and the contract lasts until the end of 2024. And so we're going to be sharing where CCOs are now, and obviously more progress will be made over the coming months and years. Also, the recommendations that the Health Policy Board came up with in 2018 were based on what was happening at that time. The landscape has changed, and some of the recommendations aren't as relevant anymore, and we'll be touching on that in a few instances. And then finally, obviously, there's been a pandemic, and COVID and public health emergency has certainly impacted the ability to implement and kind of make progress in recommendations, and we all recognize that. So next slide. So just I'm going to be going over a little bit of setting the stage of what happened in the CCO 2.0 development process. So in kind of the latter part of 2017, Governor Brown asked the Health Policy Board to provide recommendations in 4 areas for improving. The governor wanted CCOs to focus or improve in the future. And so those are focusing on addressing social determinants of health and health equity, increasing the adoption of value-based payments and paying for performance, improving the behavioral health system, and maintaining a sustainable rate of cost growth. Next slide. So this is a high-level overview of the almost about 2.5 to 3 year process that was in place to launch the new CCO contracts in 2020. And the policy development and public input process is really focused on the 2018 period. So next slide. So this is a lot of detail and just essentially provides an overview of the various mechanisms for obtaining public input in the policy development process that really occurred in 2018. And so some of the key ways that OHA in partnership with the Oregon Health Policy Board received input was an online survey that was broad-based, survey of Oregon Health Plan members. We held statewide forums, consulted with our tribal partners, and all along the way, there were report outs and touch base periods during Health Policy Board meetings. So next slide. So now kind of getting into the essence of today's presentation. So in the materials you all received, there were 2 documents or supporting documents. One was document 7.1. It was a CCO 2.0 policy recommendation tracker. And this is a tracker that Dave and I worked with many in the Oregon Health Authority across the divisions, the subject matter experts, kind of the lead in the areas of the 43 recommended policies, to get an assessment as to whether the implementation of the policy recommendations has that been fully met or on track, partially met, or not implemented or not met. And like, for example, in some cases that the recommendation was not implemented because there was a lack of money within the agency to dedicate toward it, or some key legislation did not pass. So now getting to this slide, this on the in the table, you see the different categories of the 43 recommended policies. And so the implementation of those policies we found is that 58% of the recommendations were met or on track, and 83% were met, on track, or partially met. So then if you can move to the next slide. So then also on the policy tracker, the attachment 7.1, you'll see on the right-hand side some information about whether intended impact was achieved. So that is different than whether the policy was implemented. So if you look at attachment 7.2, it was an appendix to the original Health Policy Board recommendations report that came out in the fall of 2018. And that appendix has information for each of the 43 policies on the intended impact of the policies. And so once again, we went through the 43 recommended policies and looked and worked with the subject matter experts or the leads within the agency to identify whether that impact had been realized. And so what you see here is that it's a bit lower than the actual kind of implementation of the policy recommendation. So with regard to intended impact, you see 42% of intended impacts were achieved, and 58% of intended impacts were achieved or partially achieved. So next slide. So now I'm going to be going over kind of a summary or highlights of the status for the policies, and then pass over to Dave to kind of finish them up. I do want to point out that the stoplight colors that you see on each of these slides were our assessment on the progress toward the intended impact, not necessarily on the recommendation itself, implementation of the recommendation itself, but has it had the intended impact? And then on each slide, you'll see the check marks when an intended impact kind of has been achieved, whereas when there isn't a check mark, that's where there are some issues that might have come up. But in general, we kind of synthesized all those by kind of the overall category that the Governor Brown asked us to develop recommendations in, and came up with a kind of a color coding. And then finally, at the bottom of each of these slides, you'll see the recommended policy numbers, and that is a way for you to crosswalk that to the Appendix A, the attachment 7.2 in your materials. So first, the focus on social determinants of health. In general, CCOs are achieving the intended impacts in this area. They're spending a portion of their net income or reserves on social determinants of health and health equity or disparities. And this is through an initiative called the SHARE initiative that OHA has launched. And it's in conjunction with legislation. They're increasing spending on health-related services. They're strengthening their community advisory council, relationships with their CCO, and the CAC CCO partnerships, meaningfully engaging consumers in the CCO's work and strengthening relationships with tribal partners. There's sharing of information between the boards, community advisory councils, and tribal relationships. They're sharing that information, kind of how those relationships work with OHA, and collaboratively developing community health assessments and community health improvement plans with hospitals and public health departments. In addition, some measures and metrics around health equity and social determinants of health have been adopted for the CCO incentive measure set. There are some minimal issues that were identified in this area around verifying the status of linkages between the CCOs and their community partners, kind of the ability of OHA to verify those. It does not work through the deliverables that we receive. While each CCO does have a tribal liaison, in some cases, the tribal liaison doesn't have a role in deciding on spending on social determinants of health. And then there was a recommendation on making sure that CCOs had specific funds to address their members' health-related social needs or social determinants of health. That program did not go through because of lack of funding. However, with our new waiver, you've heard about the health-related social needs and transition services. And so there will be some supports in that area to help meet that kind of intended goal from a few years ago. Next slide, please. So now moving to the focus on health equity, and this is with regard to intended impact, kind of gets a yellow, so partially met, but not fully met the intended impact. So while, so there's one kind of series of recommendations on ensuring that CCOs had health equity infrastructure and expertise built in. So while we found that all CCOs have a health equity plan, a single point of accountability for health equity work, and a culturally responsive training plan. So those were the policy recommendations. When it comes to the intended impact, not all CCOs have a standardized health equity infrastructure or expertise kind of that's embedded in their structure thus far, or the capacity to reduce health disparities, that it doesn't exist yet. Similarly to the traditional health worker recommendations, we found that while all CCOs have a traditional health worker plan and they have a THW liaison identified, they haven't all implemented the THW Commission best practices or engaged the traditional health worker affiliated organizations in their work or implemented sustainable payment rates for their THWs. And then the extent to which the actions have expanded the THW workforce and increased access to THW services, which was also a stated intended impact of these policies, is unclear at this time. And so next slide. There's a recommendation around spreading value-based payments and paying for performance, as I mentioned. And what we found is CCOs are on track with meeting their goals around expanding their use of value-based payments. They've increased the percent of provider payments that are based on value-based, that are in a value-based payment model. They've increased the types of VBP models implemented via the required what we call care delivery areas. So these are value-based payments in the hospital arena, behavioral health, and maternity care, and then oral health and children's health care will be coming over the next few years. And then they have also implemented a per member per month payments, these kind of infrastructure payments for their patient-centered primary care homes. So now if you go to the next slide, and I'm going to pass it on to Dave to take on the behavioral health system piece. Dave, are you there?
Can you hear me now?
Yeah, we can.
Okay, good. Sorry about that. As Chris mentioned, I'm Dave Inbody. He, his, him. I'm the CCO Operations Director for OHA. I'll pick up where Chris left off. I think one thing to note, as you may have noticed, more than a third of the recommendations were focused on behavioral health. So we've broken up behavioral health into a couple different categories here to better review it. The first one is looking at integration and structures. And for this one, we felt like there wasn't a lot of this we didn't make a lot of progress here. And I think part of this is as a result of the timing, obviously with the public health emergency, and also the fact that there were a significant number of priorities for behavioral health. And I think as it relates to this didn't necessarily receive the same level of attention as others had. Well, one thing we did see structure-wise, obviously the CCOs are fully accountable for behavioral health benefits, but we did see limited progress in terms of access. And this is something you'll see a recurring message, especially as it relates to behavioral health in reference to network capacity and the availability of workforce. While there's no metrics to track milestones for behavioral health or oral health integration, there are some examples. And I think it's worth noting that the CPOs do, as part of their TQS submissions, identify examples where integration has occurred. And we have seen examples where that is happening, and there are active efforts there. What we don't necessarily have is a broad metric to track that, how we're performing overall. And it didn't appear that there was a lot of integration as it related to billing systems, which was one of the priorities. And oftentimes there's policy barriers in relation to that. Some progress was identified in promoting and expanding integration, as I mentioned. But again, it wasn't necessarily universal, and there was kind of starts and stops. And again, I think there were implications to the public health emergency that limited some of this as well. And then the effort, there was a recommendation to implement trauma-informed care practices. We don't have a requirement in that regard. Next slide, please. This is specifically as it relates to the workforce. We identified it as kind of in progress or still work to be done. Obviously, there's a lot of investments that have been made and efforts to be made, initiatives to focus on behavioral health workforce. But as I think all of you are probably aware, there's still a lot of work to be done there and a lot of progress to be made. Another was focused on peers, and although peers do exist within all the CCO regions, the ability to support member access to culturally and linguistically appropriate services is still limited. We do see that there's still some work to be done there as well. Next slide, please. This is focused on children and pregnant women. Again, this is a place where there has been some progress, but there's still work to be done to meet the intended impacts. First, as CCOs, they've developed multiple entry points, but still we find that there's not adequate prioritization, and that integration still work to be done there. Achieving a system of care for children's behavioral health system is still a work in progress, obviously. And then while the CCOs are responsible for wraparound services, we found that there wasn't necessarily the capacity to meet those needs. And so there are wait lists, which was something that was intended not to occur, that we were not wanting to promote, but we do see that that's still happening. Next slide, please. And this is kind of the other categories of priorities and recommendations in the area of behavioral health. They have taken responsibility for the Oregon State Hospital wait list, and that was in January 2021. However, the CCOs do not have the shared limited risk for members currently at the state hospital. And I think there's a variety of reasons for that. Part of it is that there's been a lot of changes in terms of the population that are currently at the state hospital. I think originally the intent was heavily focused on the number or percentage of civilly committed individuals that were going to the state hospital. Well, that's shifted, and many of those people are currently, while they may be on a wait list, they're being actually served within the community. So there's more of a community focus there. And so a lot of that attention, a lot of those energies and resources have been focused more at the community level as opposed to focused on those that are at the state hospital as it relates to the CCOs. Intensive care coordination, we do have CCOs providing that to prioritized populations, but there's still some inconsistency as it relates to coordination of care across the board. This is an area where there was over the course of 2022, there was a learning collaborative related to care coordination, and that work continues. We have set up a work group that's actually developing, identifying areas where there can be changes to the contract and to rules to potentially improve the work and clarification around coordination of care. So this is a place where there has been a lot done, but there's still a lot to do, and there's work being done there. Next is, as it relates to the network adequacy, we do have quarterly reporting across the continuum of care, but we really don't have a good mechanism to assess what adequate capacity is at different levels. Right now, much of the network adequacy focus is on time and distance, which doesn't necessarily tell us the whole story. Much more focus is, we're looking to have much more focus on the access to care and timely availability of appointments. We've done things, for example, this year we did the secret shopper efforts that basically highlighted places where this work was being done and that people were getting in for appointments. But again, this is another area where we are focusing and will continue to focus. The shift of adult mental health residential benefits to CCOs that has not moved forward. And I think that's been kind of put on hold until a lot of the efforts and a lot of the initiatives that were put through in 2021 are in place, and then that can be reassessed. But currently that hasn't moved forward. Next slide, please. The next area is focused on the health information technology, and this one we had identified as many of which and many of the original intents were promoted. There's still a couple of things to be done, but the CCOs have now submit an annual HIT roadmap that speaks to the work that they're doing in this area and where they intend to go. The financial role for statewide HIT, public and private partnerships, have shifted from OHA to CCOs. Example is the Emergency Department Information Exchange. There's increased access to telehealth. Now, again, the public health emergency, I pushed that a little faster than it probably would have gone on its own, but we're there now, and we're trying to make the most of that situation to figure out exactly what the best way to use telehealth and promoting that moving forward. And the behavioral health and oral health providers are using EHR at a higher rate, but as you heard earlier in this meeting, there's still only about just over half of behavioral health providers are currently using EHR. So there's still work to be done there. The incentive program to support the behavioral health providers, HIT, didn't occur. This was not the legislation that was developed to support this in 2019 didn't pass. And so that didn't move forward. So there is not an incentive program in relation to that, which was one of the recommendations. And the CCOs are working to ensure contracted providers have access to HIE, but they don't necessarily have all the information needed deliver the cost-effective, better care. So one of the things was making sure they had access, but then the second step was through that access, making sure that they are able to provide care in a more cost-effective way. And we haven't necessarily seen that relationship yet. Next slide, please. This is focused on we have a couple of slides on maintaining to maintain sustainable cost growth. The first is on payments and incentives. The performance-based awards led to the efficient use of medical services, an increase in delivery of both high-value services and HRS. And HRS is a good example where the use of performance-based rewards has had an impact. Quality-directed payments were implemented and have been implemented and utilized. The withhold structure, we did use it in 2020, but it was suspended in 2021 due to COVID. There's still consideration of bringing that back, but that's one of the recommendations that still, we can't say we've completed that one. And then there is consistent reporting from CCOs on expenses, on their expenses. So that one has been met. So we've identified this area overall as a green. Next slide, please. Next, this focuses on the area of pharmacy broadly. There were two areas here. One was, as it relates to reducing the cost, the pharmacy costs by greater visibility to what's happening at the PBM. Well, the PBM contract readiness assessment was established, and they are submitted on an annual basis. But that hasn't necessarily reflected a reduction in pharmacy costs. The alignment of fee-for-service and CCO preferred drug lists hasn't occurred. So that was something that was recommended, but it hasn't been moved forward. So we've identified this one as in progress. Next slide, please. And this is reporting and financial oversight. As it relates to this area, the financial reporting and solvency standards have been implemented. The CCOs have been held accountable for achieving spending growth targets. The encounter data validation study, there was a recommendation that a study be conducted, an extensive study. That didn't happen, although as part of audits, we do encounter data validations, or do encounter data validation. But the overall study, the broad study has not occurred. Solvency thresholds have been established to evaluate CCOs, and there are corrective actions in place if those aren't met, and they have been utilized at times. The last one is the statewide reinsurance pool. That was not established, although there is some tools available. That was not one that was established. So we identified this one as in progress. Next slide, please. This is the last area focused on compliance monitoring. The recommendation was the establishment of a team committed to monitoring and enforcing the CCO contract requirements. We did do that. It's currently a team, the quality assurance team, that has a team of people that are focused specifically on the requirements as they appear in the contract. And these are some of the things that were set up as part of that group, as part of that team. There's an extensive annual CCO contract restatement process that is created to modify and clarify the contract requirements. Guidance documents, reporting templates, and evaluation criteria have been developed for each of the CCO deliverables, and those are provided to CCOs at least 90 days before those deliverables are due. And then there's a deliverable tracking tool that's been created to monitor the CCO's performance. And so we've identified this one as having been achieved. Next slide, please. So this is a lot of information, and I think there's a lot of information that we also provided to you through the tracker and looking at the appendix that was provided originally. And I can say that that appendix has been incredibly valuable in the work moving forward. And I know a lot of work was put into that on the front end, and I think it really has given some guidance in terms of carrying out the components of the 2.0 contract. And so with that in mind, we have two areas of questions that we wanted to pose to the board. The first is as it relates to the current CCO progress. First, just what are your reactions generally to the progress that we're making? And And I guess I would say not just the CCOs, but I think it's also a reflection of how OHA has carried out the expectations of the board. And then is there additional information that would be helpful to you as it relates to the progress that's been made?
Great. Thank you so much, Dave and Chris. Any questions or answers from the board based on the questions that Chris and Dave are presenting to us? And if we could do just stop screen sharing for a sec, be helpful. Thank you. Yeah, thank you so much for the presentation. Thoughts or questions from the board? John.
Well, first, I want to thank you all for those of us who were there when this was done. It's great to find out how it went. And I think that's important feedback and accountability for us. And I really appreciate that. I think to some degree it would be interesting to know in some of the areas where these weren't met, was that on the basis of a few CCOs not meeting it, or all the CCOs not meeting it? Meaning, you know, the CCOs maybe as a group did not think it was a good idea. For example, the high cost risk pool that was mentioned. You know, was that an idea that eventually, you know, none of the CCOs supported, or some did, or you know, is it a problem of a few, or a problem of many? Then, you know, obviously, I got to admit, I thought the integration of behavioral health would work, and would work better than it seems like it has. In my own practice, I was always fortunate to have integrated behavioral health, and I now realize how lucky I was, because it looks like that concept has struggled. Again, is it struggling in some places but succeeding in others? That would be useful to know. I mean, as I mentioned when I made my report about High Talk, you know, that the gap of almost 50% for behavioral health in terms of electronic medical records, that's daunting. That is really daunting. And, you know, because I've been interested in interoperability and the easy access to health information by patients, I think, oh my. So patients of half of mental health providers can't easily access their notes or their information electronically. It also means that those mental health providers can't access physical health information as easily from an interoperability point of view. And so without that infrastructure, it just suggests there's going to be, you know, more difficulties there. But thank you all for doing this. And sometimes I think you learn more from the things you struggle with than the things that you know, work out well and there's no problems. But it's good to have that out in the view of the public, and good feedback for us. Thanks.
Just a couple of comments. I appreciate that that feedback. Yeah, to I think your initial question, I think it's kind of all over the board in terms of the reasons why certain things were achieved or not achieved. I think it starts with OHA, which priorities did we have? I mean, I think that's one of those areas where you can definitely see the places where we prioritize that have really moved forward. But then, you know, each CCO has that ability to address some of these. And I think integration is a great example. As you said, there are those who have recognized the value that's placed and have put priority on that. And we've seen that in how that's been promoted, but that hasn't been universal. And that's something that I think in many ways we haven't put that forth as as OHA, put that forth as high a priority as we have other things. So I think in some ways that may have gotten lost. But I think generally speaking, that there's a lot of places where we've seen progress, but that we haven't progressed as far as the expectation was. And again, we're only halfway through the contract, and the hope is that, you know, over the next 2 years, we may be able to continue to make that progress, so that the intention is that we're able to get much closer to that original intent by the end of the contract period.
And I'll just add, John, with regard to your question about the reinsurance pool, I just looked at the tracker to refresh my memory, and that was something that OHA actually didn't implement. It was postponed due to COVID. So kind of goes back to my initial comment about, you know, this is an OHA and CCO kind of have had control in certain areas, and COVID has had an impact, and that's one of the areas. So that helps.
Brenda.
Thank you. I have a question and a reflection. I am curious if we have a timeline loosely established about the procurement process itself.
Are you referring to the next procurement process?
Yes.
Yeah, and that's kind of the second part of the questions that we had for you is, you know, how these results could be utilized in the next procurement process. Yeah, part of this is our first step, our first official step is that we need to submit a report about where we want to go with the next procurement process by the end of the year to the legislature. So that's the work that's being done now. We've had a few internal meetings about it. I think generally speaking, you know, the timeline starts next year. And so the part of where we're going in looking at this, kind of looking back at what we've done last time, during the current contract, is what can we utilize from either from that process or from the results that we've seen that can be applied to the next contract procurement process. And I think the second part is that the expectation, or I think the intention, is maybe that it isn't as huge a lift as we did with 2.0. One thing about the current contract is there were a number of identifiable initiatives and new areas that we have grown into. This time around, we do have many new things coming out of the waiver that was just recently approved, and that'll be the basis of part of it. But also the hope is that we can build on what we've already put in place in many areas, so that we're not starting from scratch or starting new, but we're trying to build, again, those places where we've seen progress to continue to progress, and the places where we've struggled a bit to kind of retool and refocus. But our intention is to start that process in the coming year.
Thank you. Having been part of the board during the time of CCO 2.0 procurement, I'm recalling about how important it seemed to do the statewide listening sessions. We listened to CCOs across the state. We listened to community-based organizations, consumers and constituents of the health plans, and informed ourselves an awful lot about the things that I think we were blind to. Perhaps not parts of the state were blind to all of it, but it really illuminated where some of our challenges were within the system. You know, based in our world of health equity and wanting to really listen to community, I think that that is a really important procurement step we'll want to make sure to, I personally am advocating for. So if asked the question, I'd like to do that with some deliberation and time. You know, not that we're just layering in a bunch of additional work in an already compressed and stressed system, you know, that we're asking healthcare and we're asking our CCOs to respond to, but mostly to listen to that stress system, understand where our policy is getting in the way, and even in our contracts, both the way that we interpret what the intention was and what's actually baked in contract, to glide that path a little bit more smoother. I hope, and knowing that, you know, the agency itself, you know, post-election will be well positioned to be able to start to execute on those ideas. So I look forward to a draft procurement timeline that offers us kind of a set point around what is our goal. I know you're asking that of us, and I know that we've done this before. So as the leadership is considering the timeline itself, I would hope that we have time to really engage this health system to understand where that right level set of tension we ought to be placing it now.
I appreciate you pointing that out. I think the other consideration on that as well is the listening session format the format we would want to use moving forward, or is there another format that we would want to integrate the community engagement? Because one consideration is, to what degree do we want the community to be more involved in the decision-making process? It's one thing to listen to what they're saying. It's another to include them in that process. And so we're trying to figure out how best to do that. But definitely that the engagement of the community is a critical part of this. That'll probably be a significant portion of the effort and time in 2023.
I think for me, in addition to sort of doing that community engagement, is also being very thoughtful about how we leverage the existing committees, right? And the amazing community members that are included in those committees, and bring this up and get their input, and they're supposed to advise us and provide guidance to us as well. So making sure that we are involving the committees that report to the board.
I'll just note that we definitely did that for the first phase, and I didn't mention it in my presentation, but absolutely we'll do that for this one as well.
John?
Yeah, as I reflect on this, I think it would be good in the relative near future to clarify what the role of OHPB will be when it comes to behavioral health. That was a priority for us back 4 or 5 years ago when 2.0 was done. And then really behavioral health, I think, came off of our priorities. And now it has returned to some degree. Ebony functions as a liaison to the mental health folks, but I mean, frankly, I'm a little confused about, what role we will be playing, if any role, in this very complicated area, and an area that, clearly fell short when it came to 2.0. So, myself, I'm very satisfied that there be one focus of accountability for OHA when it comes to behavioral health, and it would just be good to know who that is, and if it's not OHPB, that's just fine. At least we know who it is.
Thank you, John. Jessica?
Hi, I'm just frustrated with the behavioral health situation. We have some of the worst systems in the country right now. And, we can sit in this meeting and self-congratulate everybody about, this great body of work that is happening in all these other areas. And yet our systems are not getting the job done. And I don't know I really don't know what else to say. I mean, I sit here month after month. I don't see any real forward progress. We've got this, emphasis on health equity and all this other, wonderful stuff. It sounds great, but the people who actually need those services are not getting them. I called today actually to get someone into Columbia Care to get signed up, and they said they're 8 weeks out to even assigning a provider. We've got some serious problems here, and it's frustrating again to sit here and listen to this committee talk about all the great things that are happening, and yet we have not been able to get the job done. We need to do that.
I think it's important to note that I think the results are different depending on where you're looking as well. I think there has been progress made in some, but I agree with you that we've seen challenges with access to care. And in fact, that's one of the reasons why we're redirecting our network adequacy attention towards that. Instead of saying, do you have enough providers in your area? We're saying, of the providers in your area, can you actually get in and get an appointment, or are they taking new clients? Because it's a better indication of how well or how available those services truly are. But I think that it is fair to say that there are challenges in some places, but I think it's also fair to say that many services are being provided and many people are being cared for. We did see a significant increase.
Hold on. Where are they being provided well? Because I'm having a hard time seeing it. Again, I live in an area that's 250,000 people, maybe 280,000 people, right? The whole region. And I've got, as I'm going onto the freeway to get onto the freeway to go home, I'm seeing, people that are clearly in crisis going to the bathroom into the grates on the sideline, on the side of that freeway entrance. We live in a small area. There is something very, very wrong with the way that our state and this agency is handling some of these issues.
Yeah, I don't disagree with you that there's a significant challenge ahead. I mean, there's still a lot of work to be done. But I think it's important to note that we did see a significant increase in the number of people that are covered by Medicaid in Oregon. Through the
services. That's the problem.
Yeah, like I said, their services have been provided. It's just that we do have, as I mentioned, a limited number of people available to provide those services that are creating some of these long waits. And that some of the efforts that were being made and some of the investments that were made are not going to be immediate in terms of the implications or the impact they're going to have. For example, we're working everywhere from encouraging more people to go into the fields that would then be serving people on the front end. That's something that wouldn't pay off for many years, but also we saw an increase in the rates that we were paying for behavioral health in an effort to try and increase the availability of services and to keep people to staying in the field, because people are leaving the field as well. But I don't disagree with you that there are a number of challenges still ahead in terms of ensuring that the people who need services are receiving them. But I think it's also important to note that there are some efforts being made to try and curb that.
Yeah, and kind of going back to John's comment, I totally hear the need to prioritize behavioral health as we continue to move this work forward. Clearly, based on the results that we're seeing, it's got to be a priority as we move forward. And I think we've been starting to have conversations about the 4 priority areas of the board. I think it's definitely time to revisit those, take a look at those, refresh them, and to start kind of setting that direction of what we want to focus on. I have a question, Dave, Chris, has a portion of this presentation, or specifically speaking to the behavioral health pieces, been presented to the Behavioral Health Workforce Committee? I know that they're very focused and busy on this metrics, right? Like they're very focused on creating that metric. So this wouldn't be I wouldn't want this to be like a distraction from the creation of that metric, but it could, basically help inform that work. So I'm curious to hear about the connection with the Workforce Committee.
Well, this board was our first stop. Since the recommendations came from this board, we figured should start here. But I would welcome any other recommendations in terms of where this information should be shared. And I think that's a good place to start, is Behavioral Health Workforce Committee, because they are in the process of developing those metrics. But it would be helpful to identify, which of these areas are still in need of support, or that need to be improved and might be highlighted as a component of those metrics. But I would be interested if there are other places where you think that this would be valuable.
I mean, a couple of other committees I think about are like the workforce committee, but I wouldn't want to speak for Brenda, but I think that they should be aware this is a workforce issue as well. And then I imagine that this would also be important for even like the health equity committee, but there could be others. John?
Yeah, I just want to say that I think over the 40 years I've been involved, behavioral health has been so difficult, and you know, we've really failed in multiple tries to make progress. Some of it, frankly, is I think while the state, because of Medicaid, the state hospital, a variety of other reasons, clearly plays a lead role. I must say that commercial insurance and Medicare are a problem when it comes to behavioral health. I mean, being on Medicare now, I appreciate Medicare is not a great behavioral health provider. As I've talked to friends and talked to behavioral health folks, and as a result of other activities, Medicare is terrible when it comes to behavioral health coverage. You know, that said, for a variety of reasons, I mean, Jessica's comments are correct. We are at the back of the pack in figuring this out, and you know, I think somehow we need to figure out the next time around at this for there to be accountability, better focused. You know, I'm not sure the CCOs all by themselves can solve these problems when it comes to behavioral health, and integration won't solve these problems. So we need to get much better at this somehow or other.
Other comments, thoughts, questions? You know, I think you posed a question about how OHPB, what role should OHPB play in the next procurement process? And I'd personally like to have, you know, the board play a fairly involved role in the terms of like making sure that we're getting consistent updates on how the procurement process is moving forward. So, but that's just me. Dave, you referenced a report due in December that's going to the legislature. Can you talk a little bit more about that?
Yeah, there was a budget note in our 21-23 budget that asked that we bring forth a report before the end of this year that basically reflects what our intentions are for the next procurement process, what we want to prioritize, and what we need to basically accomplish that. So that's something that we're working on currently. And that's something else that I think would be of value maybe to bring back to this group as well, to speak to your interest in this board being involved in the procurement process. It's kind of I see it as kind of that first official step in starting the next procurement process, but it's laying the groundwork of how we want to proceed and what process we want to follow. So that's kind of that initial part of it, but it could be something that would be worth discussing here as well.
Yeah, would that report be, or that presentation be ready for the December board meeting? I know it's early December that we meet.
I can plan to do that. If that's something the board would like, we can do that. recognizing that they probably wouldn't be submitted until the end of the month, but at least the framework for it we can provide and seek input from this board.
I'd hate to have you work through the holidays, but we would love a presentation in early December, even if it's just the framework.
I think we'll be doing that work anyway, so there's no problem.
I'll just, sorry, Oscar. I mean, I just really want to say that I think it is a critical role that OHPB plays as we think about guiding this process moving forward. I know we're kind of speaking to it as individuals, and I think collectively, it was one of the most stabilizing forces, I think, both for navigating the complexities between community input, CCO input, the agency input. We have a neutral ground that we can stand on, and we're all informed based on our own perspective and disciplines. And so I think that we can be a really important and I think strategically vital part of the process. So that's what I would hope that we lead toward. Thank you.
Great. Any other thoughts or comments? Okay, so I guess we will continue to stay connected and get another update and report about this next month. And it sounds like Chris and Dave will connect with Ebony and the members of the Behavioral Health Committee and try to present something to them. I think they're meeting fairly regularly, so probably trying to get in front of them sooner rather than later would be a good. Jessica?
I think I would like to see a real plan to solve some of these issues. And a plan to execute that. Again, updates are not obviously working. So what is the plan, and how do we get, our director in here and able to execute that plan? Because what we've done so far doesn't work at all. Again, we have some of the worst behavioral health services in the whole nation. And that's outcomes based. I mean, you're looking at the data that is coming from the state. It's absolutely horrendous. We need a plan to fix it.
Yeah,
Are you talking about the plan? I'm sorry, go ahead, Oscar.
Yeah, I agree. I think I would not just the report, but I think it's going to be the beginning of like starting to create the timeline, sort of the thought process around should we start calling it CCO 3.0 now, right? Like behavioral, like the focus on behavioral health. So is that what you were looking for, Jessica, or is it so much more specific to just behavioral health plan?
No, well, behavioral health, a plan for behavioral health would be great, but I think in general, I think we need to relook at some of the goals. And again, this committee, if that's what we're supposed to be doing, is holding that system accountable, we're not doing our job right now. Because we're not getting any real major improvements, and especially in that really critical area. It shouldn't take 5 years to have some positive movement. But the problem just continues getting worse, and we don't have a solution. We have reports and updates. That's not good enough.
I'm wondering if we're working from different foundational assumptions about what progress and movement looks like. And I wonder if that retrospective study through the data could help us identify where there are wins and where there are major losses in our service line specific to behavioral health. I'm aware of some wins. They're small and they're important to build on, so I think for us to manage this kind of complexity of a conversation, it's important to look at the assets that we've invested in, the mechanisms that we think we can stand on, while we also say there's a big road ahead and that stretch is really significant. And in the meantime, we're losing lives of people in our community that we really care about, and that's preventable. So I think I'm with my colleagues here as I think about the passion and the purpose behind getting after it. What I think it would be most helpful, along with the planning that we're describing, is to understand where we build some capacities that we feel confident on.
Yeah, I do appreciate that, the idea of identifying, what progress would look like, and clarifying. And so it is something that we then could follow more closely. I think one of the challenges just in going through this exercise was recognizing how many different places we had focused recommendations related to behavioral health. And like I said, it was over a third of the recommendations were behavioral health related. And I think sometimes that spreads it out and it makes it difficult to see overall what has moved forward and what is still lagging in a way that's clearly more readily understood. And so I think that may be something as we move forward that may be helpful to do some of that, where we're more clearly identifying what the critical components are and where we're seeing progress and where we're not. I appreciate that.
Yeah, I think some of this really we need to take a look at some legislative recommendations as well, because again, without the right tools and without the right structure, we're not going to be successful. And I feel like we've really gone in the wrong direction when it comes to a supportive set of legislative structure around this work. And if the structure doesn't allow for us to be successful, we've got to start with that first.
John.
I remember soon after the 21 session ended, though, hearing a presentation from the legislature that I think that they came up with $500 million of additional funding in behavioral health. Frankly, I was kind of surprised they managed to do that, and it didn't include getting half of mental health providers into the electronic world, because that seems so basic. Most of the physical medicine world is in the electronic world because of very substantial subsidies that the federal government provided to do so. And somehow or other, half of our behavioral folks decided not to pursue that. I'm not expert at that, but the legislature deserves some credit for trying to spend a lot of money. And
so John, the money isn't the problem. I think we've got some other big issues. We have money in this state. It's not being spent strategically to get the outcomes that we want. And this is a real issue. So I think it's not necessarily about, money helps if you have a good plan and you have the right legal structure in order to implement things. If you don't have that base, you could be hemorrhaging dollars and not get anywhere, which is, I think, a lot of what we see right now. Again, we need a plan that is executable, and I'm not seeing. There's always an excuse as to why something doesn't get done.
No, I hear you, and it really worries me.
Yeah.
And from an OHPB point of view, I'm not convinced that when it comes to behavioral health, we can figure this out. I frankly think we've done a pretty good job in these other areas and gotten some very significant things done. But I'm not sure who could get that done. This is a good discussion.
Other states get it done.
So we're almost wrapping up. So I'm going to move us towards closing here. We got 4 minutes. And, I was surprised. I think one of the questions is like, what did you think about what's going on? And there's 40 plus recommendations that were part of this whole process, and half of those policy recommendations were implemented, and nearly half of the intended impact was actually has been accomplished or is on track. And this has been during a pandemic that we've been experiencing over the last 2+ years. So I would say that I was actually surprised. I think it's normal for us to focus on what hasn't been done, and what we're experiencing is still needs a lot more work. I think that's normal, and that's fair, and that's our job, and we should continue to do that. But I do want to say that I was kind of surprised that so much had been made over the last 2 years, when everybody has been so focused on the response to the pandemic. So looking forward to continuing to move this forward. In December, we have another educational webinar on Tuesday, November 15th from 8 a.m. to 9 a.m. The topic of that webinar will be the Healthcare Market Oversight Program, which we launched in March 2022. So hopefully we can have the members join us on Tuesday, November 15th. Yes, please don't forget to vote. And our next board meeting will be on Tuesday, December 6th from 8:30 to noon. Thank you everyone so much for all your work and your dedication to this. Have a good rest of the day, everyone.